But one thing about that very huge prostate is that instead of doing the tri-lobe technique, it's quite difficult because there's no space in lifting the prostate lobe, especially the lateral lobes, away from the capsule. And so what I did was, because there's no space, I did I sliced or I chopped off some part of the left lobe first, and before I proceeded with the enucleation technique. That way, I made a space for the enucleation technique of detaching the lateral lobes from the surgical capsule. So I think I also heard from other foreign experts that about 30. They say that the learning curve is about 30. For me, yeah, I agree with that number. About 20, 30 cases before you can get the hang of doing the enucleation technique. Thank you.
Okay, thank you. Thank you, Dr. Lasala. I have another question here for Dr. Albert Aquino. I think this is from Dr. Chai Dong Cao. He said, thank you for your presentation, Dr. Aquino. In the case of a full staghorn stone, how long do you need to do mini PCNL?
Doing a full stag, if you're starting to do a full mini PCNL, I suggest you don't start with that kind of stone burden first. Okay, but if you happen to have to encounter that kind of stone burden, my maximum hour or before you start it, you have to tell the patient that you might not able to completely remove all the stone. So at first, so that you would have so that there will be a patient, your patient will be aware that it may happen or it may not happen. Okay, but for me, if doing a full staghorn calculi, my maximum time will be around 2 hours, unless I have no active bleeding or the stone is it's not that kind of infectious kind of stone. So, and if you have a stable vital signs all the way with no problem, I think up to 2 hours is okay. And then the amount of fluid that you are going to, you have to be also aware of the fluids that is coming in and coming out in your inflow and your outflow, so that you will have a balance of your fluids. And always take it a point that you must have safety first before. It's better to have a safe surgery rather than a patient with compromise because of that you cannot finish you cannot completely remove all the stones. But as for my I always say to my residents, don't start with that kind of stone burden if you're going to do the mini PCNL. Or you have also, you can shift if you happen that stone is too high and you need more aggressive lithotripsol like the ultrasonic, you can change your sheet and convert it to a standard PCNL.
Okay. Thank you, Dr. Aquino. Just to continue, I would like to invite our panelists, Assistant Professor Pruit Tiratrakarn from Thailand, Dr. Chatchawet Loratsap from Thailand also, and Assistant Professor Tanan Bejarananda from Thailand also. Hello, sirs. Good afternoon. Any comments and reactions from the panels for our speakers?
Okay, thank you. Impressive speakers. So, question for the PCNL the position of the PCNL that prone or supply that may affect to the the outcome of mini PCNL that maybe which position maybe is better or have the lower complication. Maybe I ask the question for the speaker for PCNL, Dr. Aquino.
The question is for Dr. Aquino.
Yes.
Yeah.
Again,
Can you?
Dr.
I have a hard time to understand the question. Can you?
For my question is the position of PCNL's prone supply for mini PCNL. This is affect the outcome.
I think he's asking about the position of the procedure.
Okay.
Supine or prone, which is you think more beneficial? Yeah.
Okay, I'm more to tell you honestly, I'm more of the prone guy. Okay, so I'm not like Professor Carl is doing both supine and prone, but I am very happy with my position of prone because still I believe that whichever is comfortable for you, whichever that will benefit the patient most. I think that is the position that will be most better for the patient. Okay, so I'm still. I think prone is still to stay. Okay, that's why I'm still using the prone, and I have very much my room for my puncture is very unlimited in doing a prone position rather than in the supine position. Although I may be biased because I'm not that kind of doing more of the supine position. Maybe in a few years, I will also doing the supine position. But for now, most of my patients or most of that, almost 100% of my cases will be in the prone position in doing the mini PCN. But I think some of our friends from I think from Korea, they are already fan also of the supine mini PCNL.
Thank you, Dr. Aquino. There's a question here from the panelist also. This is for Dr. Lasala. This is from Dr. Chachatwet Loratsap. He's asking about how do you select patients which is suitable for outpatient fashion and the detail of perioperative management, like using which catheter, CBI or not.
Thank you, Professor, for that wonderful question. For me, most of my patients, I do outpatient basis, and unless some of my the most or most patients that were admitted for the procedure of laser enucleation are only minimal in a sense that when the patient is just a referral, so the patient was admitted by other urologists or other specialists and was referred to me for surgical management of BPH. And but the thing that I admit or the patients that I admit from my clinic are, for example, the patient has a high-risk cardiac patient. I would like to admit the patient for observation intraoperatively and postoperatively. The first patient that I had when the patient is on antiplatelet, both on aspirin and clopidogrel, and that I think I performed that procedure in my first 30 cases. So at that time, I'm not yet that confident yet. So I admitted the patient on aspirin and clopidogrel. Good thing is, just like what the literature says, that it's safe to do laser enucleation even on patients on antiplatelets. It's true that when you do proper enucleation of the prostate using laser, whether it's holmium or thulium, it's not that really what they call high risk for bleeding, no? Not so they are still so suitable for laser enucleation. But some also patients coming from provinces that has a logistical problem of going home on the same day. Those are only the patients that I admit. So high risk cardiac patients, and only with patients with logistical problem on going home on the same day. Basically, almost all patients with enlarged prostate, regardless of size, I can send them home safely, regardless of the size of the prostate. I hope I answered your question, Professor.
Thank you, Dr. Lazala. There's another question. I think it's a follow-up question. I think you forgot to mention about how about the continuous bladder irrigation? Do you do it like overnight, or do you have it right away?
The second question. Yeah, thank you for that, Carl. I usually place in a not too big catheter. No, for example, for Filipinos, I just use French 20 or French 22 three-way Foley catheter and put the patient on continuous bladder irrigation. For patients on outpatient basis, I just continue it for at least more or less 4 to 6 hours. So I do the procedure in the morning. About late in the afternoon, the patient is already ready to go home. So we can stop the crisis at that time and send the patient without crisis and only with the Foley catheter. And I remove the Foley catheter upon follow-up in the clinic, which is usually the week after. But I think we can, based on a lot of literature, we can actually remove the Foley catheter as early as the second post-operative day, or some would say even the day after the procedure. But for me, I'm a bit conservative in terms of prolonging the catheter in. So I just remove the Foley catheter 1 week after, so in the clinic.
Okay, thank you for that. In addition, I would like to say also that sometimes I also prolong the catheter. In the literature, we can let the catheter stay for about 24 to 48 hours. But for me, I add another day or two just to have it, just to be confident about everything, even though we know the patient can survive or continue on without the catheter after 2 days.
Yeah. Can I add an additional
Go ahead, Dr.
suggestion? Just recently, I had a problem with that one patient that I did thulium laser. I think I mentioned this before. Last week, Carl, to you. The patient, after removing the catheter 1 week post-op, the patient complained to me of having difficulty in urination, in voiding, and the output has a blood tinge. And it worsened to the point that he has really difficulty in voiding. So I advised him to be admitted, and lo and behold, when I when I did a cystoscopy and evacuation of clots, because on ultrasound there's about 30 to 50 ml of blood clots. So I just did a emergency cystoscopy evacuation of clots, and what I was quite surprised, because I also saw a small fragment of the prostatic lobe, which probably I missed. When I um, when I think back what happened, maybe the prostatic chip or the prostatic small prostatic lobe that I missed was not inside the urinary bladder, but it was in the prostatic fossa. So when right now, uh, learning from my mistake before, I tried to look also not only on the bladder lumen, but also in the prostatic fossa, which is now spacious, where the some of the prostatic tissue might be lodged, and which we may miss in the morcellating. So that's it. Thank you.
Yes, of course, it usually happens when you have a small chip and then your bladder neck is really wide or wide already, and there's no narrowing, and then because of a little bit of bleeding, sometimes it gets covered with blood clots, and then you don't really notice it when it goes to the fossa. Again, thank you, Dr. Lasala. Do we have other questions from our panelists?
Thank you, Professor Tan. I have one question from Professor Lasala. If young urologists or non-experienced in about evacuation of prostate, do you recommend which one is between standard therapy, bipolar, evacuation, holmium, or thulium? I know you are big fans of thulium, but and in your experience, you please recommend your equipment, your technique that you recommend to young or non-experienced urologists, please.
Thank you very much for that question also. So for me personally, contrary to the humble experience that I shared earlier, because I did most of them using thulium, I'm more of a holmium guy. But the problem is the institution that I have a holmium, they had a problem with their morcellator. It's not working. So I stopped bringing my patients there. So that's why I shifted to thulium. But when I use thulium, bear in mind that I use the coag, just like Professor Carl here taught me. You use coag. Why? Because it is there's less charring, and when there's less charring, you would appreciate more the plane when doing the enucleation, the blunt dissection. And when you use the ablation or the incision, laser incision, wherever you point it, it will really go through it, and it's prone for injury. But, so I would probably be I prefer holmium, but for now, while the institution that I'm going to has no morcellator yet, I'm still using the thulium. But in terms of the bipolar or bipolar enucleation of prostate, I'm a few years ago we had this postgraduate regarding that, and I'm quite impressed in using it, and I'm really excited when we will be getting one of those by stores, na the equipment that we will be having in one of the hospital that I go to, that I will try it eventually, and hopefully I would be able to compare which one is better. But literature has already mentioned that a lot of studies have already mentioned that laser is a better choice compared to bipolar TURP, compared to bipolar enucleation. Probably because of when you use laser, you almost don't have to think anymore. Why? Because the size is not a limitation. if the patient is on antiplatelet, you don't have to think of other things. You can still use it. Bipolar, I don't know if it's still is also safe as using laser in patients on antiplatelet when you do bipolar enucleation of the prostate. Definitely, the bipolar and monopolar TURP is not recommended in those kinds of patients. So if you have very big prostate, amenable for open prostatectomy, you just use laser instead, or even if the patient is on antiplatelet. So for me, probably I'm still for HOLEP, but it's not yet available for my consumption. So I'm for my second choice, thulium for HOLEP.
Thank you, Dr. Lasala. Any other questions from our panelists? You have more questions, sirs? Yeah, okay. I'm going to add a little bit from the question of Professor here. Yeah, me also, I do some enucleation of the prostate, and I have no experience with regards to bipolar. But if you're going to ask me whichever energy that I'm going to use, I would just choose. I will just check first if it's appropriate for the patient. Example, I would rather use Thulep in patients who are in antiplatelets. Why? Well, for me, Thulep would give more control of bleeders. With regards to HOLEP, if it's like a very uncomplicated case and it's not really, I don't have any other factors coming in that would cause complications for the enucleation of the prostate, I would choose holmium also. So actually they are in equal footing, but the only thing that the only reason that I will choose Thulep is if because of same with Dr. Lasala, the availability and if the patient is on anticoagulants. So that's just an addition to his answer.
Okay. I have one question about the laser, please, Professor. A short question.
Yes, go ahead.
Yeah. How many times that you about the uses of laser fiber for thulium?
How many times
the degradable of the fiber laser?
How many times do we use the laser fiber? Is that the question?
Yes.
Yeah. So with the machine that we're using, I think we can only use it for 15 times. Or 10. Yeah, some machines would be available for 10 usage, and the others would have 15. I think it's similar for both me and Dr. Lasala and even Dr. Aquino. Dr. Aquino also does some enucleation of prostate too. But usually the availability is usually we use it's about 10 to 15, and sometimes it also depends on how much energy or wattage have you used on that laser fiber. So there's a detection there that they would tell you that if it's used enough already. So you have to change the fiber.
Carl, can I add on that?
Yes. Yes, sure. Go ahead.
Actually, I think his point is the economy of using the fiber laser. Okay, so for our cases here in our hospital, in order for me to maximize the usage of the laser, I think the maximum time for one fiber is approximately an hour. Okay, so if you're going to subsequently do the cases, for example, a 20-minute case or a 30-minute of lacing time, or you can maximize the use of the fiber, because if you turn it off the laser machine, it will count as one already. So for our cases in our hospital, to extend our lacing time or the maximum usage of time of our fiber, we schedule patient subsequently so that we can use one fiber only, but we can do it in 3 patients. Okay. And also, I would like to add on also by using bipolar, holmium, and thulium laser for enucleation. I think for starting, I have lucky enough to be under the supervision of Professor Lucien Xiao, who's also doing 3 kinds of dose energy. Actually 4. They're also using now the diode laser. But anyway, for starting, I think the bipolar inoculation now has a role also, because especially for our residents, because we're more familiar with the bipolar. So I think it's easily to convert into TUR from inoculation to TURP. It will be much easier for those our younger urologists who wants to train for inoculation. Thank you.
Okay, nice point there, Dr. Aquino. We have a question here from Dr. I. Wayan Yudiana. Good afternoon, Dr. Aquino. What do you think or recommend if we must perform multipuncture PCNL? Should it be single site or one hole or multi-site? Thank you.
So for multiple puncture of PCNL, actually there's already a study that single site.
He's asking, or he or she's asking, if it's a single site or one hole. So you're going to do the puncture from one hole, or you're going to incise in different multi-sites.
I think for mini PCNL, you can do a single site puncture for multiple access. I have some patient already done that. I do only a single incision or one site, but two different calyx. But my maximum for that single site puncture would be a 218 and 114 French of suction sheet. But if you're going to make it 3, it's a little bit, I think you have a difficulty in maneuvering in the area of the collecting system already. But a 218 is okay.
So is it in that case, would you go for a multi-track already?
If I can access the collecting system with a single puncture, I will do that. But if it will give me a difficulty time of maneuvering or doing from one system to from one calyces to another, then I will choose for a different puncture for that.
Okay. There's another question here. He wants to remain anonymous. He was asking if, again, just to clarify, how long do you do your mini PCNL, especially in Staccon cases? For Dr. Aquino.
Yeah, as I said before, I think my maximum time or allowable time for me to do the mini PCNL for Staccon will be around 2 hours. Or I can extend it from 2.5 hours or close to that. If I see the patient will be a more of stable side, I'm always coordinating with my anesthesiologist, my assistants, what will be the status of my patient. I'm more concerned of the status of the patient rather than on finishing or having a stone 100% or more than 90% of stone-free rate. If doing that, if we're going to have a case of a Staccon calculi with mini PCNL, I think it's much better that the patient or the relatives of the patient knows that it might have a second stage or a third stage procedure, rather than pressuring yourself to do a one-stage procedure for a Staccon PCNL. But for purposes of discussion, I think my maximum around is 2 hours if it's stable. But if not, I can end it in an hour or else, or less than that. But most of the time, it's around 2 hours. That's my maximum. Finish or not finish, you have to finish. You have to stop. Stop.
Okay, thank you for that, Dr. Aquino. In the interest of time, we're going to get one more question from the panel from Professor Loroatsap. This is for Dr. Lasala. Usually, he said he prefers HOLEP, same as your suggestion. But do you have any experience with urinary incontinence after TULEP, which is frequently happens during the blunt technique, and how to prevent this complication? He's like suggestion is like apical liberation technique. Dr. Lasala?
Yeah, thank you for that question. Usually, fortunately, I haven't encountered incontinence as of yet. Hopefully not. But most of the time, I always am very worried regarding the location of the external sphincter. And I usually make sure that I do not cross beyond the veromontanum, wherein the location of the external sphincter is quite near already. And that's why when I see the veromontanum, I point the laser fiber towards the right, but not really laterally. I mean, so much so that I would not go more distally from the veromontanum, so that it will prevent in injuring the external sphincter that would lead to incontinence. If for example we are lost in the dissection, we always look back, as they say, step back and pull the cystoscope out a little and look for the veromontanum, so that you will be reoriented where you are going to do the dissection. I hope I answered your question, Doctor.
Yeah, thank you for that, Dr. Lasala. Yes, usually what we usually tell everybody is what's important are the landmarks, so you won't get lost. Usually the veromontanum is a very important landmark. And yes, I agree with you, Dr. Loratzap. I also do an early apical release for the sphincter, so just to prevent the temporary incontinence. Okay, so I guess this is a very wonderful discussion, and we are already out of time. Thank you very much, Dr. Lasala. Thank you, Dr. Aquino. Thank you to our panelists. I think we are going to proceed with the second session, or we have a coffee break after this. Thank you again. Thank you, AUSET.
Thank you, guys.
Thank you, Professor Kao. Okay, let's move to the next session. Good afternoon, ladies and gentlemen. I'm Shinake Keswan, Assistant Professor of Urology from Lama Tibeti Hospital, Bangkok, Thailand. I will be the moderator in the new technology in endourology session today. That consists of two topics, including thulium laser fiber and water vapor therapy for BPH. The first speaker who will talk about the thulium laser fiber that may be the game changer for stone surgery today. And with higher abrasion speed, with a higher efficiency, better dust qualities, and reduce the lethal portion compared with the holmium yak laser. Our speaker is currently professor at Department of Urology, Fredericia Hospital, Denmark, director of the Urological Research Center at Hospital Little Bell, University Southern Denmark. He has a lot of very high citation research. With his H index of 25 at Scopus. At present time, he is a very, very big name endourologist in Europe. Please welcome Professor Pale John Slot Oster.
Thank you very much. And it's a greeting, a good morning greeting from Denmark. It's early morning in Denmark here. And thank you very much for inviting me to this very prestigious event. I will try to share my screen here. Just a moment. I hope you see it. So what I will share with you some views and some data on what I could call the new kid on the block for stone management, the thulium fiber laser, focusing on efficacy and safety. So when we are looking into clinical data for a specific treatment, there are a lot of aspects that affects the clinical outcome from the perspective of the patient. And there's only very few treatment modalities in which we have data that embraces all these aspects. So with regard to thulium fiber laser, it's rather new. So the data is rather limited, although the amount of data is increasing. And recently, we are moving from case series into controlled trials. So I will share with you later. However, when we are sort of expanding our indications for stone management and we are using new technology without having high-level evidence, it's very important to focus on safety. As our old friend Hippocrates said, make it a habit to at least do no harm. So definitely I will focus on both efficacy and safety in my talk. So what's the difference between sort of the gold standard of stone management, the holmium YAG laser and the thulium fiber laser? Well, the thulium fiber laser has a wavelength of 1940 nanometer, which means it's very close to the water absorption peak. And this, from a theoretical point of view, should translate into better stone ablation, and also due to the fact that it has a lower penetration depth in tissue, also should translate into a better safety profile. Well, and when comparing it to the holmium fiber, to the holmium YAG laser, it has a more than 4-fold higher absorption in water, absorption coefficient in liquid water. So when looking into clinical data, it's important to sort of differentiate between efficacy and effectiveness. Efficacy is how does an intervention perform under tightly controlled ideal settings, versus effectiveness is how does an intervention perform in real world condition. And this is, of course, the ultimate data that we want. Initially, the thulium fiber laser was introduced by a group in Moscow, led by and published by Martov and all. And the initial data was very exciting. And they all concluded, both with regard to flexible uteroscopy and mini and micro PCNL, that it was effective and safe for lithotripsy. So this was the first data. And this made me, and I witnessed some of the first treatment, and seeing is believing, as you know, and I was very convinced that this laser might have something new to add in stone management. So let's have a look on the data so far. And this can be read in a recent publication, in a recent systematic review in the current opinion of urology. And I will focus on some of the aspects that's addressed in this systematic review, focusing on safety, quality, and efficacy. So what about, I would look into ablation efficacy, look into the dusting ability of this laser. How about retropulsion, and also a few words on the optimal settings and the laser fibers for this laser. And as I said previously, also focus on safety. So regarding ablation efficacy, there has been up till now a rather large amount of data, of in vitro data. This was one of the first studies by the Fried group, and they clearly showed that at equivalent settings, the ablation rate was significantly higher for the thulium fiber laser, and they studied the hard stones of the calcium oxalate monohydrate stones. And this has been confirmed by several studies after that. And the in vitro data clearly states that the thulium fiber laser has a higher ablation rate. So this is exciting from the point of view of efficiency. Let's just share a few cases from my experience. This is different cases with different stone analysis. And as you can see on the CTs below, that these stones could be effectively dusted within a very limited amount of time. So also the initial clinical experience in my hands definitely made me excited with this laser. I was able to do my stones quicker. And this has been also documented in other case series. There has been quite a few published recently, which all conclude that this is a very effective laser with regard to stone management. And this effectiveness of the laser is, from my point of view, basically or mainly due to the fact that it has a very nice dusting ability, which also has been shown in vitro studies that has concluded that it has a 4 to 5-fold higher dusting rate compared to the holmium YAG laser. It's able to produce dust from all stone types, even the hard stones, calcium oxalate monohydrate, and brucite stones. It produces smaller particle size, which results in smaller residual fragments. And also this will translate, or at least theoretically translate into a reduced need for baskening, which may translate into a higher safety profile. And what you're seeing on this video, this is the dust that you really want to achieve when you are doing dusting with your laser. Dust flowing around like this will leave the system subsequently. Part of this is due to the fact that the thulium fiber laser has a lower peak power compared to holmium YAG at equivalent energy settings. And as you see on the curves on the left, the blue curves are the thulium fiber laser, and the other colored curves are the holmium lasers. So even compared to the holmium Moses technique, the retropulsion curves are at a much lower level for the thulium fiber laser. And this will result in a higher laser fiber to stone contact. And this will create a better ablation rate as seen, a better ablation quality as seen on the figure on your right. So what about the optimal settings? Well, the optimal settings, we have now had sufficient amount of time to sort of to give you some idea on the optimal settings. However, it depends on the stone type, location, anatomy, whether you want to fragment, dust, or popcorn, whether you're treating, of course, stone or tissue. You will have to personalize your approach to management. However, as you can see from the videos, that practically, and in fact, all stone types, you are able to produce fine dust, for instance, cysteine, calcium oxalate monohydrate, and of course, calcium oxalate dihydrate. And also, which is seen from the appetite video, with the settings that, with the right settings, you're also able to popcorn. With this laser, you are able also to do very precise cutting with these very small fibers. The laser has a very good coagulative ability, meaning that it doesn't bleed when you're using it on soft tissue. And as you see on the left, on the lower right, it's in fact extremely good for coagulating upper tract tumors. So in my experience, I've completely shifted to the thulium fiber laser when treating upper urinary tract cancer, carcinoma, low-grade tumors, UTUC. So it has proved until now to be a very versatile laser, being able to deal with both, with all kinds of stones and also for soft tissue. Regarding the fiber sizes, they come from 150 micron up to 940 micron. And these very small fibers gives you a better irrigation when you're using a flexible uroscopy. It will result in less retropulsion and more precise dusting. And furthermore, the 150 micron fibers are very resistant to bending. And this is more safe for your endoscope. And they also suffer less from back burn. The increased, the small fibers and the less retropulsion will result in smaller stone fragments. However, still with higher ablation volumes, as it has been shown in vitro studies, and you will have better irrigation. And this will result in both shorter OR time, which I show you with my case series, and this potentially will result in also safer surgery. Recently, this review was published in the British Journal of Urology, showing, discussing the different details of the thulium fiber laser. It has an air cooling system, which means that it's a much smaller machine and weighs way less than a holmium fiber laser. The noise from the machine is less. It has the versatility in pulse width, in frequency, in pulse energy, and power is extreme. However, I have sort of in my hands, I'm using very low settings. It's very effective even in low settings. So I normally say to my residents when they start using thulium fiber laser, I tell them stay low and get high, and then you can adjust your settings accordingly. So all these states that I have presented to you until now has mainly been in vitro series, in vitro data, and some case series. Some of them are rather large. However, recently, a new publication is evolving. It has not been published in paper yet. However, it has been, we are allowed to see the data because it's in press, but European Urology has released it. And this is the first prospective randomized clinical trial comparing thulium fiber laser versus holmium YAG laser for ureteroscopic lithotripsy. It's a study from Norway, from Bergen in Norway. I will just share with you the data of this study. This was a randomized controlled trial that did a proper sample size calculation, and it was performed in the way that a randomized trial should be. 120 patients were randomized, 60 for holmium YAG and 60 for thulium fiber laser. And what's very important also from this study is that the outcome was evaluated by CT on bone window. This is the outcome at 3 months. And you see that's a clear, the outcome was clearly better for the thulium group, looking at the cases with no residual fragments above 3 millimeters. This was significantly higher in the thulium fiber group. And also the zero fragment cases, the cases in which zero fragments on CT was achieved, was significantly higher for the thulium fiber laser. So stone-free rate was significantly higher. So the in vitro data that showed us that it has a higher ablation rate for the thulium fiber laser was clearly translated into better outcome in this randomized controlled trial. So what about safety? Well, in the reported case series, there has been reported no serious adverse events. It has a higher resistance to extreme bending, which also is potentially more safe for your ureteroscope. It has been claimed that the thulium fiber laser might give rise to higher temperatures. However, the data that you have from the in vitro study have shown that there's no clinical relevant differences in temperature increases between thulium fiber laser and holmium YAG laser. However, you have to remember that when you're using high power lasers as high power holmium lasers and also thulium fiber laser, this will produce increases in temperature, and you have to be aware of this. And we are using non-heated irrigation fluid when we are using the thulium fiber laser, and especially if you're working with the laser in a confined space, like for instance in an impacted urethral stones, you will have to have your settings very low and secure that you have sufficient irrigating in order not to achieve too high temperatures. So what about the safety in the randomized controlled trial? Again, here, thulium fiber laser proved to be a safe procedure. The total adverse events, in fact, was significantly lower in the thulium fiber laser due to the fact that bleeding is, we have less bleeding with this thulium fiber, probably because you have a very good control of your laser lithotripsy due to the fact that you have no retropulsion, and also the long-term postoperative complications. There were no differences between the holmium group and the thulium fiber group. So definitely with the data we have until now, the thulium fiber laser has proved to be a very versatile laser, both for stone management and soft tissue management. We still need control trials for soft tissue management. But however, with regard to stone management, we have now achieved a laser that have qualities for dusting that is considerably better than the standard holmium YAG laser. So thank you very much for listening. I'm happy to take any question.
Thank you so much, Professor Pali. Actually, we have 3 panelists, Professor Associate Professor Takaki Inui from Japan, Assistant Professor Tanya Thailamong from Thailand, and Dr. Sayut Kanchana Trayon from Thailand. My panelists, do you have any question or any discussion to Dr. Pali?
Thank you, Professor Pali. Really nice presentation because of really aspect about the thulium experiments today. And I have any question about the size of the thulium fibers. Is the claim about compare between the thulium and holmium is thulium fibers can be used as small size In the paper, I see the 50 micron fiber for flexible scope. If you have any experience for this, small fiber is suitable for the flexible scope or not? Thank you, Professor.
Thank you very much. It was a bit difficult to hear the question, but what you're asking about the 150 micron fiber?
I see in the same paper is the report about the size of the fiber is less than 100, for example, 50 microns.
Oh yeah.
50 microns.
I don't have experience with the 50 micron. I think that the 150 fiber is very. I still think it's rather difficult to use it during surgery. You have to get used to use these very small fibers. So I think in my hands the 50 micron fiber is I think it's a bit too small, and I think it will prove to be rather fragile also. So for me, the 150 is definitely small enough, and it gives you irrigation, a better irrigation. But maybe a younger hand will be able to use the 50 micron fiber.
Thank you for your fascinating presentation, Dr. Oslo. I'm Dr. Srayut from Thailand. I have two questions to ask you. Firstly, in terms of the structure of the UPJ or urethra, do you think that thulium laser is better than hormone laser to manage the structure of the UPJ or the urethra? And the second question is about the cost effectiveness of the thulium laser. And do you think that in the future, can it replace hormone laser in all operation of endourology? Thank you.
Thank you very much. Very important questions. I have had quite a few experiences with urethral strictures, and I find it very effective for cutting, because you can have a very fine cutting due to the fact that there's no retropulsion, and it has a very good coagulative effect, meaning that it doesn't bleed. And this is I think it's due to less retropulsion. It doesn't push away blood vessels, as we can see with the holmium fiber laser, with the holmium YAG laser. So for tissue cutting, it's very precise, and you can do very precise cutting. So also for urethral stricture management, I've shifted to the holmium fiber. With regard to cost effectiveness, I think that for the machine, we have had no breakdown. We have had it for more than 1 year. And the holmium YAG lasers, they have these mirrors. We have had experience that the breakdown of the machines are much more often. So I think it's the technology is simpler, and this, I think, also will translate in a better cost effectiveness in the long run. And whether it will replace the holmium laser, holmium YAG laser, I'm not sure. It will depend. Maybe there will be some indications that the holmium laser will be better compared to the thulium fiber. I think the future will tell. We will have to have comparative studies also with regard to enucleation procedures. Still, I'm using holmium for enucleation. I think it, but clearly studies have been shown, and there's more and more data that when you learn to do enucleation procedures with the thulium fiber laser, it's very effective for that as well. But I think time will tell whether we need, and I think we will in the future will need both.
Thank you for a very clear answer. I think we have no more questions from online attendance.
Yeah.
So
Okay, Professor Hindley, do you have any question or any comment for this
Yeah.
session?
Okay, so thanks for great presentations. So very educational, informative educational presentations. So I'm from Japan, so I am an endocrinologist. So I have one question for you. So when using the trim lasers for big stones, maybe over 1.5 centimeters or 2 centimeter large kidney stones. So maybe, of course, we have a lot of tiny dust, tiny fragments in the collecting systems. So maybe at that time, so maybe do you use the stone basket or no? So maybe after operation, so you will expect a spontaneous passage. So which is better? So maybe to get your stone free after using trim fiber lasers.
That's a good point. However, in fact, we are using less basketing now. I'm a duster, as you can see, as you can see, you achieve very fine dusting and treating these big stones. If you want to do it fast, you have to use the dusting mode. Otherwise, you will spend too much time for retrieving stones. And with the thulium fiber laser, you're really able to dust, to achieve this dust as you saw in the video that just flows around and that will clear spontaneously. And this was also what was shown from the randomized trial, in which they also used predominantly dusting for their stones. So you're achieving high quality dust that will leave and this is what you should do, I think, for these big stones. Then you should dust.
Thanks.
Thank you so much, Professor Pale, for the enlightening and valuable presentation today. We really appreciate you to give a precious time to us. Thank you so much, Professor, and thank you to all panelists.
Thank you very much.
Let's move to the next session. Thank you. The second speaker who is going to talk about the water vapor therapy for the treating BPH is the very interesting and currently trendy in Thailand and Asia now, because it's a high effective and preserve sexual function. Our speaker, he had an extensive experience, faced over 500 patients a year for BPH with symptoms. And he is the first surgeon in UK to perform the Zoom. Now work as a consultant at NHS North Hampshire Hospital. Ladies and gentlemen, please welcome our world-class speaker, Professor Richard Hindley.
You can hear me okay. Let me just, I think I'm unmuted. I'm just going to get my slides ready.
Yes.
I hope you can see them, but thank you again for inviting me to talk today. I'll try and keep to time, and I'm sure there'll be some time for questions at the end. So a whistle-stop tour of resume water vapor therapy. These are my conflicts. So just to set the scene and remind ourselves that medication that we routinely give to men with symptomatic BPH do have significant side effects attached. And also at the other end of the spectrum, TURP, certainly monopolar TURP, has been shown now to have essentially been superseded by 7 or 8 other treatment modalities with a better safety profile. So we should be moving away from monopolar TURP. Where do the minimally invasive surgical treatments sit? Well, I think they sit between medical therapy and more formal cavitating procedures such as holmium laser enucleation, green light photoselective vaporization, and bipolar resection. The key to deciding who is best suited to each individual treatment, and we're now really focusing on the minimally invasive surgical treatments, or MISTs. The key to successful treatment allocation is to listen to what the patient is telling us, obviously to assess the severity of symptoms and use outcome measures appropriately to try and ascertain which of the treatments they may be best suited to. But we do need to be listening to the patient's concerns about the potential for harm with any of the treatments. We also need to be honest with our patients, and where there is a relative lack of data, we need to tell them this. So what are the main reasons for wanting a minimally invasive surgical treatment? And you know, I don't think a minimally invasive, you know, what is a minimally invasive surgical treatment for symptomatic BPH? And we could debate that at the end of this talk. But I think it's something that obviously works, has a bigger improvement than with medication. We perhaps don't get the flow rate improvement that we would with a bipolar resection or an enucleation technique, but we actually get quite a significant improvement in symptoms measured by IPSS or quality of life or BPH impact index. So we're seeing a quite significant improvement in symptoms with perhaps only a modest impact in terms of formal disobstruction. This is a list of, I think, the main reasons that patients might want to have a minimally invasive treatment. In the UK, where I work, a lot of patients are saying they would like to have the Resume water vapor treatment, or they don't want to have a TURP. Could they talk about the other options? So we have a number of minimally invasive surgical treatments now available, and but really we're going to focus today on Resume water vapor treatment. And yes, so the Resume is designed with a purpose, and this you can see here the emitter holes with the steam coming out of the needle at the tip of the handpiece, and this is the equipment that we use as a handpiece, as a portable generator. It's all quite mobile and easy to transport, and this is very different to transurethral needle ablation or microwave. It's working by convective heating rather than conductive. So a water droplet is heated to 103 degrees Celsius and emitted from the small holes in the needle that is deployed into the prostate tissue. The water vapor then disperses evenly throughout the tissue, releasing thermal energy and resulting in instantaneous cell death. Here is a small video to illustrate. The handpiece is passed up into the prostatic urethra. The button on the handpiece is deployed, and the needle penetrates through the urothelium into the transition zone tissue. You can see here in the corner of the image, there's an ultrasound image. And what it's trying to demonstrate is that the water vapor is contained by the boundaries of the zonal anatomy into which it is injected. So the water vapor is confined within the transition zone or in the central zone. We're not putting water vapor into the peripheral zone. We're treating BPH tissue. And there you can see the endoscopic image simultaneous with the cartoon illustration. And there's the white needle penetrating through the prostatic urethra. You do see some bellowing and movement of the tissues anteriorly and laterally as the water vapor is dispersing. There's very little leakage there with that particular treatment, and one will tailor the number of injections of water vapor that is appropriate with the gland volume. So essentially, this technique works by convective heating rather than conductive. So with conductive, there is an energy gradient. So you get very high temperatures close to the energy source, and then a non-uniform heat gradient as you move away from the energy source, which is not the case with the water vapor technique. These are some images of a patient 10 days after Resume on transverse and coronal sections on an MRI showing the area of tissue ablation. So the Pivotal 2 study was set up in order to achieve FDA approval in the US, and it was a randomized trial, 2-to-1 active treatment to sham treatment. And the 5-year follow-up data for this has now been published and presented, and this shows a sustained improvement in urinary symptoms, and furthermore, it preserves sexual function with good results now out to 5 years. Low retreatment rates at 4.4%. In the UK, I started treating patients with Resume in 2017, and in 2018, we presented our early experience at the national meeting. This is the first 210 consecutive patients that we treated with Resume. The gland volume a little bit larger than the Pivotal 2 study, and of course this was an audit rather than a randomized trial. If we look at the IPSS improvement, again very similar trend in terms of symptomatic improvement to what was seen in the Pivotal 2 study and in other series. Again, similar reduction or improvement in quality of life. And if we compare our early experience with the Pivotal 2 study results in terms of maximum flow rate improvement, modest but significant improvement maintained out to 12 months. If we look at IPSS comparison before and after, very similar, although we did see a slightly greater symptomatic improvement, but I think there had been some refinements with the technology and also a realization that it was absolutely reasonable to treat the median lobe. And so I think that's why our results are perhaps a little bit better, similar there for quality of life improvement. So overall, we saw a very similar, but slightly greater IPSS reduction, which was maintained out to 12 months. We didn't have any cases where men suffered deterioration in erectile function. A small proportion of patients do have drier ejaculation after the procedure, and it is important that we warn patients of this. I tend to leave a catheter in 1 day for every 10 mils of prostate volume. So a smaller gland might have a catheter for 3 to 5 days, a larger gland for maybe 10 days. We planned the number of deployments of water vapor based on the size of the prostate gland. I do like to measure the prostate, before the procedure, and we'll put a number of treatments proportionate with the length of the gland and the volume, and we measure from the bladder neck back to the verumontanum. So the objective is to produce overlapping lesions of tissue ablation. We tend to deploy the needle at 1 centimeter intervals. We follow the contours of the prostate gland, and we can, of course, not only treat the lateral lobes, but we can also treat the median lobe. I think we do need to be slightly careful in the smaller glands, because we really do want to minimize the likelihood of drier ejaculation after the procedure. And it's important not to overtreat. There is a temptation at the start to put in extra needle deployments and water vapor treatment cycles, but essentially it is better to put in a little bit too little rather than too much in terms of treatment. So what I've learned is that it's important. The water vapor treatment won't treat the bladder neck per se, and it is important towards the apex of the gland to be thinking about preserving the ejaculatory duct openings around the verumontanum. It's important to deploy the treatments at 3 and 9 o'clock and not to drop down into the 4 and 8 o'clock position, particularly towards the apex of the prostate gland. And so I think there are ways that we can minimize the likelihood of ejaculatory problems. And anecdotally, we have managed to reduce the proportion of patients with drier ejaculation, I think, as a result of making these small modifications. And if anything, rather than targeting the bulk of the tissue directly, I would tend to stay high in the prostate gland cavity. The water vapor will disperse to go into the bulk of the adenoma, and it will travel round anteriorly as well. There's no need to make anterior treatments. How do we treat men with a large median lobe with intravesical protrusion? When is a median lobe too large? Well, I think this is work that does need to be done. How we treat the median lobe in terms of the technique depends on the size of the median lobe. If it's a larger gland, I normally put a treatment in at 45-degree angle on either side. With a very large median lobe, I sometimes put treatments in at 45 degrees on each side and also one in the midline. This is a short video, I think, just of a patient who had a 52 mil gland, but with a sizable median lobe. And this was the end result after the treatment at the 6-month period. But we mustn't forget that we're not hoping to get the big cavities like we might see after enucleation, but there is definitely a cavitational effect from the treatment. Why? I mean, UroLift, of course, has an important role to play in the portfolio of minimally invasive surgical treatments, and both of these technologies are quick to perform. If I was going to make the case for the benefits of Resume over the UroLift technique, it would be that it's perhaps more versatile with larger glands and median lobe treatments. The durability does appear to be superior with retreatment rates at 5 years from the Pivotal 2 study of 4.4%, and it's at least maybe threefold likelihood of of retreatment within the first 5 years with UroLift. There are also some issues perhaps about the artifact caused by, on an MRI scan, if a patient in later life was ever suspected of having prostate cancer, although most prostate cancers are located posteriorly, some are located in the anterior gland, and there is no doubt that there is some artifact caused by the implants. And so I think it's something that we should mention to patients, but I don't think it's a major issue, but something that needs to be discussed nonetheless. Resume, yes, I mean, I've used Resume in patients that have had previous minimally invasive surgical treatments or previous resection. In these cases, I would certainly recommend, as well as standard things that we use for evaluating patients, it would be sensible to do a flexible cystoscopy, I think, so that we can understand, is there any scarring of the prostate cavity or to exclude a bulbourethral stricture. And for any case, I need to know the gland volume, because if the gland is 110 mils in volume, then there are probably other better treatments, and the patient may have to accept a degree of compromise with regards to preservation of sexual function in particular. I was involved with a study looking at the cost effectiveness of Resume, and this is a paper from James Ulchacker at the Cleveland Clinic, again, comparing 6 different therapies for symptomatic BPH and the cost in US dollars of reducing the IPSS in each of these treatment modalities. So there is evidence that it is cost competitive. And what I didn't mention earlier is that with each handpiece, you can deploy 15 injections of water vapor. You will never need any more than that. So one handpiece for one case, and that cost is predictable case after case after case. I have very rarely used a full 15 injections of water vapor, only in the very big glands, over 100 mils, of which I haven't treated that many. So in terms of the patient journey, I think it's a new option for men with moderate to severe symptoms. It does reduce the prostate volume by about 1/3, and it's very easy to learn, a short learning curve, quick to perform, and can be performed under local anesthetic or LA with sedation, and I'll just come on to that. It can be used for larger glands. We looked at larger glands. This is a presentation from 2019. We had 2 groups of patients, one with an average volume of, I think, 94 mils and the other 49 mils. And although it was a small study with a short period of follow-up, we weren't able to demonstrate a significant difference in terms of the symptomatic improvement or indeed the side effect profile. However, it would seem common sense that every time the needle goes through the urothelium into the prostate tissue, there is a small risk of bleeding. So the more treatments that we do, I think the likelihood of bleeding is probably a little bit higher. We have now followed up a larger cohort of patients, and we've looked at our early retreatment rates, and our 1 year retreatment rate is 2.4%, very similar to the Pivotal 2 study, albeit that was a randomized trial with strict inclusion and exclusion criteria. And this slide just illustrates there what other techniques we have tended to employ for those men that have or require an early retreatment. And we're continuing to look at that for years 2 and 3. The procedure is a little bit more uncomfortable than the Urolift procedure, but that discomfort is very short-lived. And by the time the patient has been recovered or is in the recovery area, or a few minutes after the procedure, they are generally very comfortable, and their analgesic requirements are low. There are different techniques we can employ in terms of pain management. When I started offering Resume, I followed the sort of US model of offering a periprostatic transrectal block, but also placing local anesthetic in the clouds above the mountain. So going up above towards the bladder base and putting local anesthetic on either side. I think when one starts any new technique, it's sensible to do the first cases under a light general anesthetic. But there are various techniques and ways that one can perform the procedure under local anesthetic or local anesthetic with sedation. And that will depend on local factors. In the UK, we don't have many office or clinic facilities where we could offer this sort of treatment at the moment, but I think this will change. If we're doing a procedure, we tend to be in an operating theatre, and we have an anaesthetist standing by to help us if we need them. We've been on a journey, and we're still offering this procedure under general anaesthetic or indeed local anaesthetic with sedation. In the UK, for prostate cancer diagnostics, we've moved towards transperineal biopsying away from transrectal. And so we have, and other centres in the UK have performed this procedure with a transperineal administered local anaesthetic periprostatic block. Often this will be combined with a small amount of midazolam and other analgesics. This is where we've arrived in 2020. These are the sort of options that we offer our patients. If it was a patient who hadn't previously had a flexible cystoscopy, who had been referred from elsewhere, or who I thought wouldn't be able to tolerate the procedure well, or with a big gland, I would probably prefer them to have a light general anesthetic so that there was no movement and I could safely place all my needle injections of water vapor without any movement and without any potential for bleeding. So why is Resume a good option? As I alluded to earlier, it is very easy to use. It is versatile. It can be used for treating the median lobe. I think it's fair to say that those patients might have a little bit more in the way of symptoms after the procedure, but with appropriate reassurance and plenty of information before, during, before and after the procedure is really important. This is a short video just showing the procedure again, as you saw earlier. And what I do at the start of the procedure is measure back in ½ centimeter increments from the bladder neck to the verumontanum. Then I'm thinking, okay, it's 5 movements or 2½ centimeters. Therefore, I will probably, in this gland, put 2 treatments into each lateral lobe. I will want to stay high up in the lateral lobe. I think maybe a little bit above the bulk of the adenoma. There's a little bit of water vapor leakage there, but by manipulating your hand and the handpiece, one can help minimize that. There's a little bit of blanching you'll see where in the treated area, but most of the urothelium will maintain its blood supply and maintain its integrity. So you don't get a lot of debris production or sloughing of tissues. And I think in an ideal world, a minimum amount of blanching is good. But I wouldn't worry if you see some blanching of the tissues or indeed tracking up towards the verumontanum and into the urethra. We haven't had any, we've perhaps had one urethral stricture in 800 cases, so we don't see that as being a major issue. So to conclude, it's a very good versatile procedure, complementary to any urologist wanting to offer a range of treatment options. I think its advantages are that it produces consistent improvement, predictable improvement. You get some gland volume reduction, and therefore it's more durable than some of the other minimally invasive treatments. It's very good for gland volumes ranging from between 30 and 80 mils, but I think it can be extended up to 100 mils and perhaps down to 25 mils. There are high rates of patient satisfaction, and the cost is predictable. Thank you very much.
Thank you so much, Professor Richard Hindley. The panelists, do you have any question or any comment to the professor?
Thank you, Professor Richard. It's a very clear aspect about the water balance of the prostate. Question about in case of symptomatic BPH with large median lobe, this technique can be treat the patient. For the surgical technique, we'd like to ask you about with the location that you puncture on the median lobe in case of the median lobe BPH. Thank you, Professor.
Thank you. Yes, I think it was a little bit difficult, but I think how do I decide where to place my treatments? I mean, I'm conscious of where the needle has gone into the tissue, and the water vapor is directed at 100 in 3 directions at 120-degree intervals. So I'm thinking of the direction that the water vapor under low pressure is being directed, and the angle of and shape of the prostate tissue. It's important, obviously, to stay. I think if the prostate median lobe is extending into the bladder, I think it is reasonable to move closer and towards the bladder in terms of deploying the treatments. The most treatments I've put into a median lobe is 5, and that one seemed to have a very good effect. But with a large median lobe, I've had one case where the median lobe sloughed away and then needed a cystoscopy to retrieve it at 2 to 3 months after the procedure. It is also the case that you can get a little bit more debris when you're treating the median lobe, because I think that the way that the body heals, that dead tissue can be extruded into the bladder, whereas with the lateral lobe tissue, it tends to stay out into in the transition zone lateral lobe tissue. If it's a prominent central zone, I may place one needle deployment in the midline there. If I'm happy that I'm in a safe position. I always do an ultrasound of the prostate gland at the time of the procedure, so I can understand the angle of the urethra and look at how much tissue there is below where I'm likely to be placing my treatments. I've had no cases of a rectal injury, but I'm aware that's theoretically possible. So if it's a small median lobe less than 2 centimeters or 1.5 centimeters in diameter, I would probably do one needle deployment, either from one side at 45 degrees or one treatment in the midline. If it's a prominent central zone, I might place one treatment into the midline. But with a bigger gland, I'll put a bigger median lobe, I'll put one treatment into each side. I hope that answered the question.
In case of the enlarged median lobe treat with the resumes, how many days for the catheter to retrain for these conditions?
Yeah, thank you. Question. So if a patient has an occlusive trilobar gland, and we've treated a 90 mil gland, I would probably leave a catheter in for 10 days. If it's a 30 mil gland, I would probably leave it in for 3 to 5 days. You can try leaving a patient without a catheter, but it really does need to be, I think, a younger, well-motivated patient with a modest sized prostate gland. So typically, for a moderately enlarged gland, I will do the procedure on a Monday and they will return the following Monday to have the catheter removed. But if it's a smaller gland, they might come back on the Thursday or Friday. If it's a bigger gland, the catheter will remain for a longer period of time. It is one of the downsides to resume, but most patients, when you talk to them about a catheter and what it entails, and I think are okay with the prospect of having a catheter. So it's approximately 1 day for every 10 mils of prostate tissue as a guide. I tend to leave a 16 or an 18 two-way catheter.
Thank you so much, Professor Richard Hindley, for a fruitful and very informative presentation. We really appreciate that you give your valuable time to us. Thank you so much. To the next session, thank you. To the next session, I will give the moderator work job to my friend Angie Nawaldi, Indonesian friend, to be a moderator in the next session. Hi, friend. Could you please unmute?
Good afternoon, everyone. Thank you for connected. My name is Anggi Nawaldi, and I'm a urologist from based in Jakarta, Indonesia. In this last online session, I will present you two lecturers. They are very well known in their country and also internationally for their work and publication in endourology. The first speaker comes from my home country of Indonesia, and a friend of mine and someone I look up to in endourology. His name is Dr. Boyke Subhali. He works in Abdul Wahab Shahrani Hospital and also a lecturer of urology in Mula Warman Hospital in Samarinda, East Borneo. He is an expert in endourology, especially in RIRS and PCNL, and also a consultant in urological trauma and reconstruction. He has also published several publications in national and internationally. Let's not wait any longer. Dr. Boyke, I give you the time and place. Thank you.
Hello, I'm Boyke, and I'm very honored for the opportunity to present my presentation in this Asian Urological Society of Endoluminal and Technology. I was asked to present about the supine PNL, why and how I do it. Again, it is a very big honor for me, and I would like to show my gratitude to Dr. Anggi, my colleague in Samarinda, for inviting me for this meeting, and also hello to Professor Cho. We met a few years ago in Penang. If you still remember, we talked about a lot of things in Penang at that time. Thank you. It is a huge honor for me to present in this prestigious event. When in Indonesia, I always show that I came from Samarinda in this position around here. That's where I live. We share the island with Malaysia and Brunei. I will first talk about my hospital, the Abdul Wahab Shahrani Hospital in Samarinda. It's a tertiary referral type A hospital in Indonesia, one of the main referral hospitals. We have 900 beds, and we perform 350 to 400 retrograde internal surgery per year. the rears, and we managed to prolong the age of our equipments. Our Olympus has gone more than 350, and we also have the valve, and we also have the stores, and of course the disposable ones like Boston Scientific and USET. We perform retrograde intraoral surgery with flexible ureteroscope as the main procedure for kidney stones, complementary with supine PNL. We perform the supine PNL around 250 to 300 procedures per year. This is our hospital, the Abdul Wahab Sari Hospital in Samarinda. The PNL in Samarinda, I will talk about the history for a moment. I finished my education as urologist in 2008, and I first performed the PNL in Samarinda because in my residency, I was trained by Professor Lobe to perform the prone PNL. And then in 2014, we started the retrograde intraoral surgery using 100-watt holmium laser, and we fall in love with this particular procedure right away. It is convenient. It can be performed very fast and very efficient using the 100-watt holmium laser. And in 2016, we started supine PNL and never go back to prone after that. We love the supine PNL. And then in 2016 also, another urologist, Dr. Ricky, came and we started to perform endoscopic combined intraoral surgery for complex stones. But due to our policy in the national insurance health company, then if we perform ECIRS, there will be a smaller reimbursement to the hospital, because we will have to do 2 urologists and 2 equipments and 2 sets of equipments, and the hospital are not happy about it. So most of the time we will do a stage procedure for complex stones now. And this is a historical picture of me and Paxi. Many of you know Paxi also. We come to Jogja to see Dr. Indra Warman here, my mentor, for the supine PNL, and he taught us about supine PNL in Yogyakarta in 2016. And this is my operating theater. I love being in the operating theater. Of course, we are surgeons, right? We love to be in the operating theater. And this is the lithotripters in Samarinda. The first lithotripter we find is the 100-watt luminous holmium laser. This is my baby, and I love it very much. But then in 2020, I think, we got this new toy. This is the thulium fiber laser from Quanta, and according to the manufacturer from Quanta, this is the first Quanta thulium fiber laser in Southeast Asia, and I love this. I love the dusting using this machine. And also for PNL, we use the Swiss Lithogas Master, the EMS. And this is, well, I think this is the all-in-one machine for kidney stone, I think, because it can do anything. In Samarinda, why supine PNL? Because we start with retrograde intraoral surgery, and supine PNL is easier performed when we are used to do retrograde intraoral surgery, because the same position, actually it is the same position. It looks like supine PCNL is the extension of retrograde intraoral surgery, for me at least. Shorter operating time. In Samarinda, we only have one operating theater with CM, so we have to finish the surgery in no time. For me, when I perform prone PNL before that, I feel that changing the position of the patient, it took time. So I love supine PNL because of the shorter operating time. Also, the opportunity to perform endoscopic combined intraoral surgery. By the way, I don't have residents in Samarinda, so we have to do all the position also by the team. In some places, when we put the ureter catheter, etc., performed by residents, and then after the position, then the surgeon came. For some surgeon, it will make them say, no, I don't feel the difference in the operating time between supine and prone position. But for me, to perform it all, it is a huge difference between prone and supine PNL in operating time. Like this, cystoscopy, pilography, and then we change the position and then perform the PNL. If we perform supine, and then we do it all in one position, even if we want to change the equipment, I mean, we perform PNL and then we perform retrograde oral surgery, retrograde intraoral surgery, it is all in the same position. Pros and cons, of course. The pro, anesthesia access and ventilation. Yeah. One little story here. My wife is an anesthesiologist. So, the anesthesiologist would love to perform anesthesia in a supine position patients, of course. Rather than you perform it supine and then you have to change the position to prone. It will be harder to them. So, supine position will make my life easier, will make my life happier. Because what? Because my wife, as the anesthesiologist, will be happier too. A happy wife means a happy husband, right? And then the patient positioning, right away. Positioning right away, you don't have to change anything. A shorter overall operating time, because we don't have to change position, of course. A shorter overall operating time. Also, the decrease of intrarenal pressure. Why? Because we don't push the irrigation to the kidney. We put the irrigation to the kidney, and then it will flow out because of the position of the amplacid. It will flow outside the body. Also, the decreased X-ray exposure. Of course. Why? Because, well, this is meant the decreased X-ray exposure to the surgeon, especially to my hands. Because if we do the PNL in prone position, and then our hands will be in the way of the X-ray. If we do it from supine position, and we don't have to put our hand in the way of the X-ray. It's outside of the X-ray. So it's safer for my hands. The surgeon's ergonomics. Well, I do the supine PNL in sitting position. Actually, I love doing my surgeries in sitting. I perform retrograde intraoral surgery sitting. I perform URS sitting. And I'm a reconstructive urologist. I do the urethral reconstruction sitting. So I love the sitting position. So it is a good position for me because I love doing my procedures sitting. It will help my back. It will prolong my ability to work, of course, because it gives less pressure to my back. Also, it's easier to perform endoscopic combined intraoral surgery. Also, improve upper bowel access in 80% of the cases. The contra, the kidney mobility. After this, I will show how to prevent, how to manage the kidney mobility in supine position. Also, a longer percutaneous tract. In the next slides, I will show you also how to make it shorter. Well, actually, if you put an adhesive in the abdomen of the patient and choke it, take it to the contralateral side of the patient, the tract will be much shorter. After this, you will see. And this is the guideline, the AAU guideline for kidney stone. We see here in all cases, I mean less than 10 millimeters, more than 20 millimeters, all PNL have a place in this to manage the kidney stone. Also in lower pole stone between 10 to 20 millimeters, shockwave, PNL, retrograde surgery, rears, it all have a place in managing the cases. And this is the history. Well, it is a long history from 1865, the first percutaneous kidney puncture, and then the USG PNS in 1974, and also the supine PNL in 1987, the Gadaco modified supine Valdivia position in 2001, and then the story goes. This is the prone position PNL. You see here. After we put the ureter, we change the position of the patient to prone. And this is the classic Valdivia supine position where we put the support below the lumbar. This is the Valdivia position. Here we mark the posterior axillary line, the 12 rib here, and the iliac crest. And this is our working area. Don't worry, my mentor, Dr. Indah said, don't worry about the narrow working area. Because of what? We only need 1 centimeter to work on supine PNL. We only need 1 centimeter of area. This is the Gadaco modified Valdivia position. We put the patient in almost lithotomy position, almost. And I have a little different in putting the support. I don't put the support under the lumbar, but I put it under the chest and under the pelvic. So I have a free flank here to work without touching my equipments to other support. This is one of the tricks for the to make the kidney immobile. We put a gap wire through and through the kebab position like this. PCRS is the logical evolution of PNL. So perform PNL and we do from below also. The upper tract approachability, we can reach most area of the kidney via supine position, also for multi-tract PNL. The kidney hypermobility, we can do something about it, like abdominal compression. We put the assistant put some pressure on the abdomen to make the kidney less hypermobile. Also, a gap wire to improve a kebab position like the previous slide. It will make the kidney less mobile. Also, this is one little trick. We put a urethral access sheet to the ureter to make the kidney less mobile. Put a urethral access sheet. It will help. Also, of course, using a smaller access sheet for implants. Here the positioning, mark the position, posterior axillary line before positioning of the patient. Patient supine near the border of table. Be careful. You have to know your table to know the spots, the blind spots of the table. You have to know. You have to know your table. The arm contralateral to the side to be operated abducted less than 90 degrees, slightly flexed. The ipsilateral arm crosses the chest, lying on it or supported. I just put it lying on the chest. The lumbar region lifted 20 degrees and exposed. I put my support below the chest and below the pelvic, so I have a free flank. Mark the lower margin of 12 rib and upper margin of iliac crest. Then the patient is put in modified lithotomy position. The ipsilateral leg is slightly abducted and extended. Contralateral leg is lifted and partially flexed. This is the instrument. I use the C-arm and USG. Scope, irrigation, needle, vessel dilator, Alpen dilator. Usually I use amplas dilator, amplas sheet, lithotripter. For PNL, I prefer to do the lithotripsy using ultrasound and pneumatic, much faster than laser, in my opinion, especially for large stone. And also transport and basket. Here, the X-ray safety is very important because we have to keep our body safe. And this is what I do. Dilators, we can do the Alton dilator and the Amplas dilator or the balloon dilator, like here. And this is the stone. We always do CT scan to know the anatomy and to know the hardness of the stone. This is a position. See, this is a fat lady here, and because she has a lot of fat here, then we will put some adhesive here and take the abdomen to the contralateral side and see we have a shorter distance between the skin and the kidney. If we do that, it works like magic all the time. And this is the secret is this adhesive. This is a position, and this is the marking like previously. And I love to do ureteroscopy first to evaluate the ureter. It's not well, actually it's not necessary for all cases, but I like to do it to know that if I have to do something from below, from the ureter, then I have the map already. And the exercisation, I use the combination ultrasound and fluoroscopy. And like this, I use the ultrasound position of the kidney, and we see between the skin and the kidney, we don't have any other organ. We don't have the ileum there. And we make the puncture here, like this. This you will see the middle here. Yes, and that's urine. Here we can see urine here. This is the urine, and we put the guide wire, and we dilate the fascial dilator first, and we put the antennas inside the kidney like this. So we can do the dilatation with the Amplas dilator easier because it's hard. And then we dilate. See the position here? We do the rotating and thrusting maneuver here. The rotating and thrusting maneuver. And then we put the nephroscope. See, I sit during that procedure. Sit. Very convenient. And then we do the lithotripsy here. That's it. Using the lithotripsy master, pneumatic and ultrasound. This is the sitting position, and you see, this is the Amplas. So if you have small stones here, it will go out. This is the pre-post, and this is the fragmentation strategy. And the exit strategy will be the nephrostomy, tubeless, or the stent. But me personally, I don't do tubeless PNL. Because of what? Because I don't want to make a urinoma. Just a few days of the stent with the we can put it in the clinic. We can take it out with the string. So for me, I don't do tubeless PNL. I do the nephrostomy or I do the stent. I think that's it. I hope I can give something for the society. Thank you.
Thank you, Dr. Boyka, for the very clear and step-by-step for performing supine PCNL. And for the second speaker, comes from Bangkok, Thailand, a teacher and a friend of mine, Assistant Professor Ekarin Jotikawanich. He is an assistant professor in Division of Urology, Siriraj Hospital in Mahidol University, Bangkok. He has also received many awards and birthed many publications, national and international journal. Today, he will bring a lecture about the feasibility and outcome of RIRS on Staccon stone. So without further ado, I present to you, ladies and gentlemen, Professor Assistant Ekarin.
Okay, good afternoon from Thailand, and thank you, Angie, for your kind introduction. So my talk today is about the RIS to treat the Staccon kidney stone. So I think we are running out of time, so I think I'm going to go faster. Look at the definition of the Staccon stone. Staccon stone is the large stone filled in the kidney from the renal pelvis and at least one renal calyx. Most of the time, they compose of stool white. What does it mean? It means magnesium, ammonium, and phosphate. It's usually caused by the urease producing pathogen. The incidence of the Staccon stone in the developing country is about 10 to 15% of all urinary tract stone. But in the developed country, it has very low incidence because the stone in the developed country, you all know that they usually has an early diagnosis and management. Here is our research at Siraj Hospital. We conduct the research to look at the stone composition and the demographic data of the patient. And we found that the stool white stone, we have just only overall of this stool white stone, we have it's just only 5%. But comparing with the male and female, we found that the female had 2 times incidence of the Staccon comparing to male patient. The majority of the cases of the Staccon stone is usually unilateral, and up to 15% of cases, they involve both kidney. The predisposing factor of the Staccon, that I think we all know that female extreme age, congenital anomaly, and whatever the cause that make the urine to stasis in the kidney or in the ureter, they usually cause the Staccon stone, as well as the diabetes. About the pathogenesis of the Staccon stone or the stool white stone, I think the bacteria that produce the enzyme urease. We all know that the urease enzyme comes from both gram-positive and gram-negative species. The most common pathogen is Proteus. But not every species of the pathogen that produce urease, but we know that 100% of Proteus, Providentia and Morganella produce urease, but Capsula and Staphylococcus, there was 100% of these organisms that produce urease. If we culture the stool white stone, we can find this kind of the pathogen just only in 72%. But the urease splitting found just only half of this positive exam. Here is the diagram to show you that how comes of the Staccon stone. We have the urea in the urine that we all know. Finally, with the urease, finally we get the ammonia, and it combined with the magnesium and phosphate and to become the NAP. Not only this bacteria to produce ammonia, but it also stop the protective binding mechanism of the citrate in the urine. So that's why more than half of Staccon is not just only NAP, but is also the calcium stone as well. So far, we have known that increasing of the Staccon stone without infection, we have this kind of composition increasingly nowadays. This because the hyperoxaluria has increasing by the mechanism that I have mentioned. The management of the Staccon stone, we all know that the gold standard to treat the Staccon stone is PCNL. In the past, I think open surgery would be the gold standard for treatment of the Staccon stone. But nowadays, I think after the development of the instrument and experience of our urologists, so PCNL becomes the gold standard. Here is comparing of the result about the goal of the stone treatment. We want stone free and less complication and to preserve the renal function. To achieve these three aspects, open surgery gets more stone free, but in terms of complication and renal function, I think PCNL is quite give the achievement. So what about the RRS? Because nowadays I think the RRS is an attractive procedure for our young urologists, as well as I am a young too. We are going beyond the gold standard, or we are going beyond the guideline, because nowadays RRS is not in the guideline to treat the Staccon stone. I was looking into the meta-analysis to compare the PCNL and RRS, and these are the result. Most of the paper told us that PCNL has higher stone free rate, but it has the higher complication rate and higher blood loss. This result doesn't make me so surprised, because we all know that PCNL is more invasive when compared to the RRS. So what is the role of the RRS to treat Staccon stone? What I am talking is not just only RRS to be the monotherapy, but the role of RRS going to be here. The first one going to be the ureteroscopic monotherapy, and the second one should be combined antegrade and retrograde approach, or ECRS, that we all know. Savas ureteroscopy after PCNL, ureteroscopy and followed by shockwave lithotripsy. For my own experience, I would say I have another thing to do, or in combination with RRS, or what I call it hybrid lithotripsy. I start shockwave lithotripsy and then followed by RRS in the same period in the operative theater. I think this result is quite good, because sometimes when you have the stone in the difficult location, shockwave work good, but the disadvantage of the shockwave is you cannot clear it by that time. So after break up the stone with the shockwave, and then you go inside the kidney with the ureteroscope, you can do something to clear the fragment at that time. So, here is the study by Scotland, from Scotland. They report that the role of RRS to treat Staccon stone with the URS as a monotherapy. The stone free rate is about 23% with first time, and second time the free rate was higher to around 70%, and the third time the free rate goes to around 80%. It's not quite interesting because when you treat the Staccon stone with the monotherapy of the eyes, it doesn't mean you can get rid of all of the stone just one time. You need 1 or 2 or 3, even 4 times. Here is the role of IRS to treat Staccon in terms of the ECIRS. Here is the study comparing the ECIRS to the conventional PCNL. We found that the higher stone fill rate of the ECIRS is much more higher comparing to conventional PCNL, 90% versus 65% at 1 month. And here is the stone, the information of the SAWAS urethoscopy after PCNL. This study comparing the mini PCNL and ureteroscopy and found that the stone fill rate was 80%. Here's again URS followed by shockwave lithotripsy. The stone fill rate, if you want to get rid all of this Staccon stone with this kind of approach, you need 1 more session of ESWL. In this paper, they say that they need just 8 times of shockwave, so it's quite high. Here is our experience at Siraj Hospital. We collect the data of RIS as a monotherapy to treat the Staccon stone. When we talk about the Staccon stone, the left one should be suitable to do RIS as a monotherapy, while the right one, I think the right one is not the suitable case to do RIS, but the right one, we do the combined therapy. I start with the PCNL first, and then 3 times of RIS, followed by 1 time of shockwave before get rid all of this stone. We have done 35 cases, 12 male and 23 female. As I mentioned before, that the incidence of the stool white is double in female comparing to male. The median age was around 60 years old. The median stone size was 3 centimeters. When measure the stone attenuation with the CT scan, the Half-Field unit, the median Half-Field unit was 9 and 50. Here is our result. The stone fill rate after first time was 35%. Second time was 64, while first time was 88%. I would notice you that this data we are running the research, so this figure is not quite correct because we need some time to correct the figure. So I think maybe next 2 or 3 months we can have the stable data. Here is another example of the Staccon stone. It is a full Staccon, but in this case we do just 1 time of RIS monotherapy and get rid all of the stone. In this case, I show you the case that we have done 2 times of the RIS to get rid all of the stone, and we have 3rd time as well. For my own experience, I think the last 5 cases, I have the stone size around 5 centimeters, and half-field unit was just 500. We have the first time stone fill rate achieved 100%. What different from the previous cases? One thing I think the big difference is the hardness of the stone. Even though you have the big stone, but if you have the soft stone, it can clear easily with the laser. So that's why I would recommend you, if you have to do RIS dealing with the large stone, just select cases. Select the case that I would recommend the half-field unit, not more than 500 or 600 to achieve first time stone fill rate. Yes, it's just what I have mentioned before. The stone burden is not quite a big deal, but the big deal is about the half-field unit that we measure from the CT scan. Not only the surgical intervention, but preventing the recurrence is quite important for the Staccon stone. We have to remove all of the stone burden, and the antibiotic to sterilize urine is important. But the question is how long that the patient should be given the antibiotic. I think we don't know, we don't have any guideline to tell us right now that the suitable duration of the antibiotic, how long. For my own experience, I used to give my patient 1 month and 3 months, and they all have the recurrence. So the US inhibitor used to be the agent to less stone growth. However, it had its high complication for the patient, such as tenderness and febrile thrombosis. Urinary acidification with the agents such as the vitamin C or ammonium chloride, ammonium sulfate, ammonium nitrate, methionine have been proposed to make the urine becomes acid, because we know that those pathogens grow well in the alkali environment. However, it is very difficult to maintain the acidification in the presence of the infection. That means you have to get rid of the infection before you modify the urine pH. And how can you get rid of the infection? You can get rid the infection after you get rid all of the stone. So this should be my last slide. Staccon mostly related to the UTI. The preoperative planning is very essential. The goal of treatment is stone-free and eradication of the infection with the antibiotic. Not just only to get rid of the stone, but close follow-up this patient with the regular imaging exams and urine culture is quite important. Thank you.
Thank you, Assistant Professor Ekarin, for the clear and progressive lectures on RIRS for Staccon stone. To summarize, SPCNL or prone PCNL and also RIRS has started a long, endless debate on which one is superior compared to each other regarding their feasibility, stone-free rate, complication rate, even though those procedure has been mediated by endoscopy combined intrarenal surgery. For this interesting discussion, we have three panelists today: Assistant Professor Chiang Ying Lee from Taiwan, Dr. Shamsin Sindhu Bode, and Assistant Professor Anand Bejrananda from Thailand. So any response or question from the panelists to the speakers?
Thank you for the great lecture, Professor. The yesterday and do the IIS after that.
I think you mean your question is about what I mentioned, the hybrid lithotripsy, right? So I usually start with the shockwave first, but for this kind of approach, I didn't mean I use this approach for the Staccon stone, but I just proposed about this kind of combination therapy to treat in some difficult situation. If you want to treat the stone with the RIS, but sometimes you have the very difficult situation, such as the very deep angle in the lower pole of the stone. So about your question, I would say I will start with the shockwave first. The machine that we have used as Urological is the third gen shockwave lithotripsy cement. I start with the shockwave. I don't want to go beyond 2,000 shots. So because you have the laser in your hand, sometimes you start with the shockwave because you want to reposition, make it just smaller to facilitate your approach with the retrograde access. Sometimes when we start with the shockwave first, and then we go into the kidney with the urologicals, most of the time there's no need to use even the basket to extract the stone, but just use the flow, meaning the pump flow to flush out the small fragment from the lower pole to go into the renal pelvis, and then this approach makes you feel easier to extract all of the fragment.
Okay, thank you to Professor. I have two questions for Professor Sobali. When you deal with supravisional, the first question, if you have the remaining stone like a porcelain calyx that need XLE procedure, how do you deal with this situation? And the second question is, you talk about low pressure, low intrarenal pressure, how to deal with visualization when some blood make your visualization is bad.
Thank you. I hope this is clear enough. I'm really sorry I cannot hear the first question, but I will answer the second question about the lower intrarenal pressure. Well, in my first few cases, I have difficulties in maintaining the view because of the shorter because of the lower pressure. But then I found out that, and also my mentor, Dr. Indrawarman, always said that we can use irrigation from the ureter catheter to the kidney. Then you will maintain a very good view on that. So irrigation is not only from the nephroscope, but also from the ureter catheter from the ureter from below. That's how I deal with it. But please, the first question, please, I did not get the first question.
The first question is when you deal with a Staccon stone that has many posterior calyx, do you puncture second, third puncture or not, or you use like a combined IIS to become ECIS?
I prefer to do the ECIRS. So if I found that there are stones in the calyces that I cannot reach with the nephroscope, then I will go from below and try to take the stones from the calyces, put it into somewhere that I can reach from the nephroscope, and then do PCNL on that stone. But if that's not possible, then I can always do the retrograde surgery using laser and destroy the stones. Or, and this is less likely, I also do the second puncture. But actually, I rarely do the second puncture. Usually, I can use it from below. I can do it from below usually. Thank you.
Okay, for the last question for me, I asked to Professor if we deal with a 2.5 centimeter, how feel about 1,000? Which technique do you use, supply PCNL or IIS? First,
2.5 centimeters, and what about the hospital unit? How hard?
1,000 how feel unit.
1,000 now I will perform the supine PNL, because usually if it's below 1,300, then I will perform retrograde internal surgery. But due to the load of surgery in my center, so I will, like I said, I have to finish it as soon as I can. And PNL, supine PNL or mini PNL will be much faster than doing retrograde internal surgery for the 2.5 centimeter stone with 1,000 hospital unit. In my opinion.
Thank you. The same question, Professor Ekelin.
Okay, the question is the 2.5 centimeter with the 500 hospital unit. 1,000. 1,000.
Yeah.
Okay. If the patient doesn't have any kind of the anomaly, anatomy, I would prefer the IIS actually.
Thank you.
Okay, I think we are running out of time, and this is quite interesting session for today. On behalf of the Thai Urology Association and the Endourology group of Thailand. So I would like to say thank you to AUSET for having us the opportunities to host the meeting. And I would like to say thank you to our audience here and every audience, even on site or online. And last but not the least, I would say big thank you to Dr. Manin and Dr. Chinaket. I have known that they work very hard for this meeting. Thank you and good luck for everyone.
ครับก็ขอบคุณทุกท่านนะครับที่เข้าร่วมจนจบในพาร์ทที่เป็นอินเตอร์นะครับก็เดี๋ยวเรามีช่วงสั้นๆอีกประมาณสักครึ่งชั่วโมงนะครับก็จะขออนุญาตเปิดเป็นวิดีโอนะครับก็จะมีอยู่ทั้งหมด2ท็อปิกนะครับเรื่องแรกก็จะเป็นผ
ของผมนะครับที่เป็นคนพูดก็จะเป็นเรื่องของ New Insight into Medical Expulsive Therapy for Ureteral Stones นะครับก็จะเป็นเรื่องของอัปเดตใหม่ๆเกี่ยวกับเรื่องของ Medical Expulsive Therapy ในคนไข้ที่เป็น UC นะครับว่าในช่วงสัก 2-3 ปีที่ผ่านมาเรามีการเปลี่ยนแปลงหรือว่ามีเปเปอร์ใหม่ๆอะไรบ้างนะครับแล้วก็เรื่องที่2ก็จะเป็น focus on the different aspects of alpha blocker to improve the outcome of bladder outlet obstruction นะครับก็จะนำเสนอโดยอาจารย์ชินเขตจักรามานะครับก็2พาร์ทนี้จะเป็นวิดีโอนะครับที่ได้รับการสนับสนุนนะครับจากบริษัทเอไซประเทศไทยจำกัดนะครับก็เดี๋ยวเชิญรับชมนะครับสวัสดีครับผมผู้ช่วยศาสตราจารย์พิเศษนายแพทย์มณินทร์อัศวจิรจิตเป็นศัลยแพทย์ระบบปัสสาวะวันนี้ก็จะขออนุญาตใช้เวลาประมาณสัก 10-15 นาทีในการที่จะแนะนำทุกท่านเกี่ยวกับอัปเดตข้อความรู้แล้วก็งานวิจัยใหม่ๆที่เกี่ยวข้องกับการให้ยาขับนิ่วหรือที่เราเรียกว่า Medical Expulsive Therapy ในผู้ป่วยที่มาด้วยนิ่วในท่อไตนะครับนิ่วในท่อไตก็เป็นโรคที่เราพบได้บ่อยนะครับในการทำงานของศัลยแพทย์ระบบปัสสาวะผู้ป่วยส่วนมากก็มาด้วยอาการปวดเอวข้างใดข้างหนึ่งอาจจะมีลักษณะของการปัสสาวะเป็นเลือดร่วมด้วยหรือไม่ก็ได้การรักษาเบื้องต้นก็ประกอบด้วยการให้ยาแก้ปวดนะครับแล้วหลังจากนั้นเราก็จะส่งผู้ป่วยไปทำภาพรังสีวินิจฉัยซึ่งที่เรามักจะเลือกใช้ก็จะเป็น CT สแกนนะครับหลังจากที่ยืนยันแล้วว่าผู้ป่วยมีปัญหาในเรื่องของนิ่วในท่อไตนะครับถ้าผู้ป่วยมีข้อบ่งชี้ในการที่จะต้องไปทำผ่าตัดหรือว่าระบายปัสสาวะออกโดยเร็วนะครับเราก็ควรจะดำเนินการไปตามนั้นแต่ว่าถ้าผู้ป่วยยังไม่มีข้อบ่งชี้โดยสมบูรณ์นะครับปัจจุบันก็มีการให้ยาเพื่อที่จะช่วยขับนิ่วหรือที่เราเรียกว่าเป็น Medical Expulsive Therapy นะครับก็จะมีหลักฐานยืนยันถึงประสิทธิภาพของยาแล้วก็มีการบรรจุเรื่องของการให้ยาเอาไว้ในไกด์ไลน์ต่างๆนะครับเริ่มต้นจาก Campbell-Walsh Urology นะครับซึ่งก็เป็น Standard Textbook ของทาง Urology ก็มีการยืนยันถึงประสิทธิภาพของการให้ Medical Expulsive Therapy ในผู้ป่วยที่มาด้วยนิ่วในท่อไตนะครับอีกไกด์ไลน์หนึ่งที่ยืนยันก็คือ AUA ไกด์ไลน์นะครับซึ่งเป็น Standard ไกด์ไลน์ของทางฝั่งอเมริกาก็ยืนยันถึงประสิทธิภาพของการให้ยาขับนิ่วในผู้ป่วยที่มีนิ่วในท่อไตส่วนปลายที่ขนาดไม่เกิน 10 มิลลิเมตรนะครับรวมถึงไกด์ไลน์ที่3ก็คือ EAU ไกด์ไลน์ซึ่งมาจากฝั่งยุโรปก็ยืนยันถึงประสิทธิภาพของการให้ยากลุ่มนี้เช่นเดียวกันนะครับนอกจากนั้นก็มีการศึกษาต่างๆนานานะครับในลักษณะของ Meta Analysis เพื่อที่จะยืนยันถึงประสิทธิภาพของการให้ยานะครับซึ่งเป็นยากลุ่ม Alpha Blocker ที่ช่วยในการขับนิ่วในท่อไตนะครับก็สามารถที่จะทำให้เรามั่นใจในการที่จะให้ยาอย่างมีประสิทธิภาพได้นะครับซึ่งในการที่เราดูงานวิจัยต่างๆก็จะมีพารามิเตอร์หลายๆอย่างที่เราควรจะต้องคำนึงถึงนะครับในการที่จะดูถึงประสิทธิภาพของยาพารามิเตอร์แรกที่มีความสำคัญมากที่สุดก็คือ expulsion rate หรือว่าอัตราการหลุดของนิ่วพารามิเตอร์ที่2ก็คือ expulsion time นะครับหรือว่าระยะเวลาที่นิ่วหลุดนอกจากนั้นก็จะมีอีก2พารามิเตอร์ที่เราควรจะคำนึงถึงด้วยในการที่จะศึกษาถึงประสิทธิภาพของยาอันนึงก็คืออัตราการให้ยาแก้ปวดและอย่างที่2ก็คือผลข้างเคียงที่เกิดจากการให้ยาครับจากที่เราทราบกันดีอยู่แล้วว่า Medical Expulsive Therapy มีประสิทธิภาพในการช่วยขับนิ่วได้แต่อย่างไรก็ตามตัวโปรโตไทป์ของ Alpha Blocker ที่ในการขับนิ่วก็จะเป็นตัว Tamsulosin นะครับแต่อย่างไรก็ตามช่วงหลังๆก็จะมีการใช้ Alpha Blocker ตัวอื่นๆซึ่งตัวที่ผมจะขออนุญาตอัปเดตในวันนี้ก็คือตัว Silodosin นะครับเปเปอร์แรกนะครับก็เป็นเปเปอร์ที่ทำในญี่ปุ่นตั้งแต่ปี 2011 นะครับก็ใช้ตัว Silodosin ในการที่จะมาลองขับนิ่วโดยการเปรียบเทียบเป็น randomized trial ผู้ป่วยเนี่ยเป็น distal UC ขนาดไม่เกิน 10 มิลลิเมตรนะครับจำนวนทั้งหมด 181 รายกลุ่มเปรียบเทียบเนี่ยให้กินน้ำเยอะๆเฉยๆนะครับแต่ว่ากลุ่มที่เราศึกษาเนี่ยนอกจากดื่มน้ำเยอะๆแล้วเราก็ให้ซิโลโดซินขนาด 8 มิลลิกรัมร่วมด้วยแล้วก็เป็นการให้ยาอย่างต่อเนื่องนานประมาณ 8 สัปดาห์นะครับผลที่เจอก็คือเราไม่พบความแตกต่างในการหลุดของนิ่วอัตราการหลุดของนิ่วเนี่ยอยู่ที่ 50% เทียบกับ 66% ซึ่งไม่มีความสำคัญทางสถิตินะครับอย่างไรก็ตามเมื่อเราทำเป็น subgroup analysis เรากลับพบว่าผู้ป่วยที่มีนิ่วค่อนข้างใหญ่ก็คืออยู่ในระดับ 6-9 มิลลิเมตรเนี่ยมีอัตราการหลุดของนิ่วที่ดีกว่าก็คืออยู่ที่ 52%เปรียบเทียบกับ 30% นะครับก็เป็นการยืนยันถึงประสิทธิภาพในการขับนิ่วที่มีขนาดค่อนข้างใหญ่ได้ต่อมาก็จะมีอีก study หนึ่งในปี 2015 นะครับก็เป็น study ที่ทำในหลายๆเซ็นเตอร์ในสหรัฐอเมริกาก็จะเปรียบเทียบผู้ป่วยที่มีนิ่วในท่อไตขนาดค่อนข้างใหญ่ก็คืออยู่ประมาณสัก 4-10 มิลลิเมตรนะครับกลุ่มเปรียบเทียบเนี่ยให้กินเป็นยาหลอมแล้วก็กลุ่มที่ศึกษาเนี่ยให้กินเป็นซิโลโดซินขนาด 8 มิลลิกรัมนะครับผลการศึกษาเนี่ยเราพบว่าไม่มีความแตกต่างกันนะครับใน overall เมื่อเปรียบเทียบกันระหว่างการให้ยาหลอกกับการให้ซิโลโดซินก็คืออัตราการหลุดของนิ่วเนี่ยอยู่ที่ 52% เปรียบเทียบกับ 44% นะครับแต่อย่างไรก็ตามเมื่อเรามาทำ subgroup analysis เรากลับพบว่าในผู้ป่วยที่มีนิ่วขนาดค่อนข้างใหญ่แต่ว่าอยู่ในท่อไตส่วนปลายก็คือเป็น distal UC เนี่ยซิโลโดซิน 8 มิลลิกรัมสามารถที่จะเพิ่มอัตราการหลุดของนิ่วได้นะครับก็คือผู้ป่วยสามารถที่จะนิ่วหลุดได้ 69% เปรียบเทียบกับกลุ่มที่ได้ยาหลอกซึ่งมีอัตราการหลุดของนิ่วอยู่แค่ 46% นะครับดังนั้นแลนด์มาร์คเปเปอร์อันนี้ในปี 2015 ก็เป็นการยืนยันประสิทธิภาพของการให้ซิโลโดซินขนาด 8 มิลลิกรัมเพื่อที่จะขับนิ่วได้ครับมีการศึกษาในปี 2018 ตีพิมพ์ใน plus 1 นะครับก็เป็นการทำ meta analysis เพื่อที่จะ compare ระหว่างซิโลโดซินกับแทมซูโรซินสามารถที่จะ enroll มาได้ทั้งหมดเนี่ยมากถึง 16 study แล้วก็มีผู้ป่วยที่อยู่ใน study นี้มากกว่า 1,800 รายนะครับก็จะเป็นผู้ป่วยที่มีนิ่วในท่อไตขนาดไม่เกิน 10 มิลลิเมตรทั้งนั้นนะครับถ้าเรามาดูจาก forest plot เราก็จะเห็นว่าซิโลโดซินเนี่ยมีอัตราการขับนิ่วได้ดีกว่าแทมซูโรซินนะครับโดยถ้ามาดู number needed to treat เนี่ยเราพบว่าการให้ซิโลโดซินในผู้ป่วย1รายเนี่ยสามารถที่จะช่วยขับนิ่วได้ถ้าเกิดเราดูประโยชน์ overall ในผู้ป่วยทั้งหมด8รายนะครับมี meta analysis อีกฉบับหนึ่งนะครับอันนี้เพิ่งจะตีพิมพ์ในปี 2021 นี่เองนะครับก็เป็นการทำ network meta analysis เพื่อที่จะเปรียบเทียบอัลฟาบล็อกเกอร์หลายๆตัวได้แก่ซิโลโดซินแทมซูโรซินอัลฟูโซซินแล้วก็เปรียบเทียบกับพลาเซโบนะครับตีพิมพ์ในวารสารของบราซิลนะครับก็สามารถที่จะ enroll study มาได้ทั้งหมดเนี่ยมากถึง 31 study แล้วก็ผู้ป่วยรวมเนี่ยมากกว่า 7,000 รายนะครับก็จะเป็นผู้ป่วยที่มี distal UC ทั้งนั้นนะครับถ้าเรามาดู result นะครับก็จะพบว่า expulsion rate ในการให้ alpha blocker ไม่ว่าจะเป็นซิโลโดซินอัลฟูโซซินหรือว่าแทมซูโรซินมีประสิทธิภาพในการขับนิ่วมากกว่ายาหลอกทั้งนั้นนะครับแต่ถ้ามา compare head to head เราพบว่าใน alpha blocker ทั้ง 3 ตัวเราพบว่าซิโลโดซินมีประสิทธิภาพสูงสุดในการขับนิ่วครับจากที่เราสรุปได้ว่าซิโลโดซินมีประสิทธิภาพในการขับนิ่วคำถามต่อมาก็คือโดสขนาดไหนที่เราควรจะให้ในการที่จะเลือกใช้ซิโลโดซินเป็น medical expulsive therapy นะครับเป็นการเกริ่นนำก่อนว่าซิโลโดซินที่เราใช้ทั่วโลกเนี่ยมีอยู่2ขนาดก็คือขนาด4มิลลิกรัมแล้วก็ขนาด8มิลลิกรัมนะครับแต่ว่าในประเทศไทยเนี่ยเรามีใช้เฉพาะขนาด4มิลลิกรัมเท่านั้นเปเปอร์แรกที่ผมจะขออนุญาตนำเสนอก็เป็นเปเปอร์ที่ทำในตุรกีนะครับตีพิมพ์ตั้งแต่ปี 2015 แล้วก็เป็น randomized study เพื่อที่จะศึกษาถึงประสิทธิภาพของการให้ซิโลโดซิน 4 มิลลิกรัมในการขับนิ่วเปรียบเทียบกับการไม่ให้ยาอะไรเลยนะครับเปเปอร์นี้เขาก็ enroll ผู้ป่วยที่เป็น distal UC ขนาดตั้งแต่ 4-10 มิลลิเมตรนะครับมาได้ทั้งหมด 70 รายแล้วก็แบ่งเป็น2อาร์มแรกที่เป็นกลุ่มควบคุมให้แค่ไดโคฟีแนกหรือว่ายาแก้ปวดอย่างเดียวแล้วก็อาร์มที่2ซึ่งเป็นกลุ่มทดลองเนี่ยนอกจากให้ไดโคฟีแนกแล้วก็ให้ผู้ป่วยกินซิโลโดซินขนาด4มิลลิกรัมแล้วก็เปรียบเทียบกันที่21วันว่ามีอัตราการหลุดของนิ่วเป็นยังไงบ้างนะครับรีซัลท์ที่เราเจอนะครับเราพบว่าการให้ซิโลโดซิน4มิลลิกรัมมีอัตราการขับนิ่วได้มากกว่าก็คือนิ่วหลุดอยู่ที่ 91% เปรียบเทียบกับการไม่ให้ซิโลโดซินเลยเนี่ยมีอัตรานิ่วหลุดอยู่แค่ 77%นอกจากนั้นนิ่วยังหลุดเร็วกว่านะครับก็คือโดยเฉลี่ยแล้วกลุ่มที่ได้ซิโลโดซินเนี่ยนิ่วหลุดภายใน8วันเปรียบเทียบกับกลุ่มควบคุมที่นิ่วหลุดเนี่ยใช้เวลามากถึง12วันนะครับอีกประเด็นหนึ่งที่ผมอยากจะคอมแพร์ก็คือการให้ซิโลโดซิน4มิลลิกรัมกับ8มิลลิกรัมเนี่ยมีประสิทธิภาพต่างกันหรือเปล่าก็มีอีก study หนึ่งนะครับอันนี้ทำในตุรกีตีพิมพ์ในปี 2017 นะครับก็เป็นโรผู้ป่วยที่มี distal UC มาทั้งหมดเนี่ย161 รายนะครับกลุ่มหนึ่งเนี่ยให้กินซิโลโดซินขนาด4มิลลิกรัมแล้วก็อีกกลุ่มหนึ่งเนี่ยให้กินซิโลโดซินขนาด8มิลลิกรัมนะครับผลที่ได้เนี่ยเราพบว่ากลุ่มที่ได้รับซิโลโดซิน8มิลลิกรัมมีอัตราการขับนิ่วได้ดีกว่าก็คืออยู่ที่ 73% นะครับเปรียบเทียบกับกลุ่มที่ได้ซิโลโดซิน4มิลลิกรัมเนี่ยสามารถที่จะขับนิ่วได้แค่ 50% นะครับดังนั้นก็เลยเป็นข้อสรุปว่าถ้าเราเลือกใช้ซิโลโดซิน เป็น medical exhaustive therapy โดสที่เราควรจะใช้เนี่ยน่าจะอยู่ที่8มิลลิกรัม per day มากกว่านะครับทั้งนี้ทั้งนั้นคำอธิบายก็อาจจะอยู่ที่ระดับของยาในเลือดนะครับซึ่งการให้8มิลลิกรัมเนี่ยยาจะมีระดับสูงอยู่ในเลือดได้ยาวนานแล้วก็คงที่มากกว่านะครับซึ่งนั่นก็อาจจะเป็นสมมติฐานว่าทำไมประสิทธิภาพของ8มิลลิกรัมดีกว่า4มิลลิกรัมครับอีกคำถามหนึ่งซึ่งได้รับบ่อยๆนะครับก็คือเราสามารถที่จะใช้ซิโรโดซินในผู้ป่วยเด็กได้หรือเปล่านะครับจากเดิมเรายังไม่ค่อยมีข้อมูลในกลุ่มนี้ก็เลยยังสรุปไม่ได้แต่ว่าล่าสุดในปี 2021 นะครับก็มีคนพับลิชเป็น randomized trial ออกมา trial หนึ่งซึ่งน่าสนใจนะครับก็เป็น trial ที่ทำในอียิปต์เป็น prospective randomized trial นะครับแบ่งผู้ป่วยที่เป็นเด็กมาด้วย distal UC ขนาดไม่เกิน 10 มิลลิเมตรนะครับออกเป็น3 อาร์มโดยที่ผู้ป่วยทั้งหมดเนี่ยอยู่ที่167 รายมีอายุโดยเฉลี่ยประมาณสัก11 ขวบแล้วก็มีขนาดนิ้วโดยเฉลี่ยอยู่ที่ประมาณ6 มิลลิเมตรนะครับอาร์มแรกเนี่ยให้เด็กกินซิโรโดซินขนาด4 มิลลิกรัมต่อวันอาร์มที่2ให้กินแทมซูโรซินขนาด 0.4 มิลลิกรัมต่อวันแล้วก็อาร์มที่เป็นคอนโทรลเนี่ยก็คือให้กินพลาเซโบเฉยๆนะครับถ้าเรามาเปรียบเทียบที่4 สัปดาห์เนี่ยเราพบว่า expulsion rate ก็คืออัตราการขับนิ้วได้ในกลุ่มที่ได้ซิโรโดซินเนี่ยสูงที่สุดก็คืออยู่ที่ 89%เปรียบเทียบกับแทมซูโรซินเนี่ยอยู่ที่ 74% แล้วก็กลุ่มที่ได้ยาหลอกเนี่ยอยู่แค่ 51% นะครับก็เป็นการสรุปได้ว่าการให้ซิโรโดซินขนาด 4 มิลลิกรัมเนี่ยมีประสิทธิภาพในการขับนิ้วได้ในเด็กข้อสรุปสุดท้ายที่อยากจะแนะนำให้ทุกท่านฟังนะครับก็คือเราควรที่จะให้ medical exhaustive therapy ในผู้ป่วยที่มีนิ้วในท่อไตทุกรายหรือเปล่านะครับก็คือไม่ใช่นะครับเพราะว่ามันก็จะมีข้อจำกัดในการให้ medical exhaustive พอสมควรนะครับประเด็นแรกก็คือ benefit ที่เราได้จากการให้ยาเนี่ยเราพบแค่นิ้วที่เป็น distal ก็คืออยู่ในท่อไตส่วนปลายแล้วขนาดมากกว่า5 มิลลิเมตรเท่านั้นนะครับดังนั้นผู้ป่วยที่มีนิ้วในท่อไตเป็นกลุ่มอื่นๆเช่นขนาดมากกว่า10 มิลลิเมตรขนาดน้อยกว่า5 มิลลิเมตรนะครับหรือว่าอยู่ในท่อไตส่วนต้นผู้ป่วยกลุ่มนี้ก็เราไม่พบว่าได้ benefit จากการให้ medical exhaustive therapy นะครับประเด็นที่2ก็คือเรื่อง side effect จากการให้ medical exhaustive therapy นะครับเราพบว่าผู้ป่วยประมาณ 6% หลังจากที่เราให้ alpha blocker เพื่อเป็นยาขับนิ่วเนี่ยอาจจะประสบพบเจอเรื่องของการเกิด retrograde ejaculation ได้นะครับนอกจากนั้นก็อาจจะพบเรื่องของ orthostatic hypotension มีอาการเวียนหัวหรือว่า dizziness นะครับอีกอย่างที่ต้องระวังก็คือผู้ป่วยบางรายนะครับโดยเฉพาะในผู้สูงอายุอาจจะได้รับ alpha blocker อยู่แล้วดังนั้นการที่เราไปเติม alpha blocker อีกตัวหนึ่งอาจจะทำให้ side effect จากการให้ยาเนี่ยกลับพบเพิ่มมากขึ้นนะครับประเด็นสุดท้ายก็คือในผู้ป่วยบางรายที่เราควรจะเลือกผ่าตัดนะครับในการกำจัดนิ่วไม่ว่าจะเป็นวิธีการทางศัลยกรรมหรือวิธีการนะครับอาจจะเลือกใช้วิธีการผ่าตัดไปเลยไม่รอให้ยานะครับผู้ป่วยกลุ่มนี้ก็ได้แก่ผู้ป่วยที่มีอาการติดเชื้อค่อนข้างรุนแรงนะครับผู้ป่วยที่มีไฮโดรเนฟโรซิสมีไตบวมน้ำค่อนข้างเยอะมีอนาโตมีของ KUB ที่ผิดปกตินะครับรวมถึงในผู้ป่วยที่มี renal compromise ก็คือเริ่มมี GFR ที่ดรอปแล้วผู้ป่วยกลุ่มนี้อาจจะเหมาะที่จะไปทำผ่าตัดเลยมากกว่าการให้ยาแล้วก็รอให้นิ่วหลุดเองครับข้อสรุปสำหรับวันนี้นะครับข้อแรก medical exhaustive therapy โดยการให้ยากลุ่ม alpha blocker มีข้อบ่งชี้แล้วก็มีที่ใช้ในนิ่วที่เป็น distal UC ขนาดตั้งแต่5 ถึง 10 มิลลิเมตรนะครับกลุ่มนี้เราพบว่ามีประสิทธิภาพในการขับนิ่วที่สูงที่สุดแล้วก็มีประสิทธิภาพที่ชัดเจนเมื่อเปรียบเทียบกับยาหลอกข้อสรุปที่2ก็คือการให้ซิโรโดซินถ้าเราเปรียบเทียบกับ alpha blocker ตัวอื่นๆเราพบว่าซิโรโดซินเนี่ยมีอัตราการขับนิ่วได้ดีกว่านะครับโดยโดสที่ควรใช้ถ้าเป็นผู้ใหญ่จะอยู่ที่8 มิลลิกรัม per day นะครับแล้วก็ถ้าเป็นผู้ป่วยเด็กจะอยู่ที่4 มิลลิกรัม per day นะครับแต่อย่างไรก็ตามการใช้ยากลุ่มนี้เรายังถือว่าเป็น off label use นะครับถึงแม้จะมีการบรรจุเรื่องนี้อยู่ในไกด์ไลน์หลายๆไกด์ไลน์แล้วนะครับก็คงเป็นเรื่องที่เราจะต้องรอการวิจัยใหม่ๆแล้วก็รอข้อสรุปที่ชัดเจนมากกว่านี้ครับ
สวัสดีครับผมผู้ช่วยศาสตราจารย์นายแพทย์ชินเกตเกษสุวรรณจากคณะแพทยศาสตร์โรงพยาบาลรามาธิบดีขอขอบคุณบริษัท AUSET ที่ให้ผมมาพูดในหัวข้อ Focus on the different aspects of alpha blocker to improve outcome of DOO วันนี้เราจะมาพูดถึง DOO กับ Alpha Blocker กันครับหัวข้อที่ผมจะมาอธิบายให้อาจารย์ทุกท่านฟังนะครับก็จะเกี่ยวข้องกับ Bladder Outlet Obstruction นะครับก็จะเป็นจริงๆ Bladder Outlet Obstruction เนี่ยอาจารย์จะคิดว่ามันค่อนข้างที่จะ subjective ถูกไหมครับแต่ความจริงแล้วมันไม่ subjective ครับอาจารย์มันจะเป็นภาวะที่อาจารย์สามารถที่จะวัดได้จริงเป็น objective โดยที่ตัวที่จะช่วยที่อาจารย์วัดเนี่ยก็จะเป็นเขาเรียกว่า pressure flow study หรือ urodynamics นะครับอาจารย์ทราบอยู่แล้วครับว่า pressure flow study หรือ urodynamics เวลาคำนวณ Bladder Outlet Obstruction Index เนี่ยถ้ามันเกิน40แล้วก็คิดว่าผู้ป่วยมีภาวะ Bladder Outlet Obstruction ใช่ไหมครับ Bladder Outlet Obstruction เนี่ยมันเป็นตัวเชื่อมครับเป็น pathophysical link เชื่อมกันระหว่างผู้ป่วยที่มีภาวะต่อมลูกหมากโตกับอาการของผู้ป่วยหรือ LUTS เป็นตัวอธิบายหมดเลยครับอาจารย์ว่าทำไมผู้ป่วยเราถึงมีอาการแล้วก็มี disease ร่วมด้วยนอกเหนือจากที่ Bladder Outlet Obstruction จะทำให้เกิดอาการต่างๆแล้วเนี่ยครับ Bladder Outlet Obstruction ยังทำให้กระเพาะปัสสาวะของเราเกิดภาวะหนึ่งที่เรียกว่า tissue remodeling นะครับวันนี้ที่เราจะมาพูดถึงกันเราจะมาพูดถึง progressive tissue remodeling ซึ่งมันจะเป็นตัวโรคที่ทำให้กระเพาะปัสสาวะเฟลเลียในอนาคตได้นะครับและนอกจากนั้นนะครับอาจารย์มันยังทำให้เกิดแรงดันในตัวคิดนีหรือ ureter สูงขึ้นทำให้ upper tract เกิดมี pathology มาเกิดภาวะ renal failure ได้ในอนาคตโดยที่ Bladder Outlet Obstruction ครับอาจารย์มันมีทฤษฎีที่เกี่ยวข้องกับที่ทำให้เกิดภาวะ tissue remodeling อยู่2ทฤษฎีด้วยกันทฤษฎีแรกก็คือในเส้นเลือดที่มาเลี้ยงตัวกระเพาะปัสสาวะเกิด insufficiency กับอีกหนึ่งทฤษฎีก็คือเราเชื่อว่ามันเกิดจาก pressure ที่สูงขึ้นในกระเพาะปัสสาวะที่ใดๆก็แล้วแต่ทั้ง2อย่างเนี่ยมันจะทำให้เกิดภาวะ progressive tissue remodeling เกิด tissue hypoxia เกิดกระบวนการที่เกิด structure ต่างๆในตัวกระเพาะปัสสาวะมันเสื่อมลง compliance ลดลงเกิด functioning ที่มันลดลงและสุดท้ายนะครับอาจารย์ก็จะทำให้ผู้ป่วยมีภาวะ LUTS ตามมาได้ครับกระบวนการทั้งหมดนะครับมี hypertrophy compensation decompensation hypertrophy เนี่ยในระยะแรกๆนะครับกล้ามเนื้อเรียบของเราจะเริ่มเพิ่มจำนวนเซลล์มากขึ้นเกิด hyperplasia กล้ามเนื้อเรียบของเราครับจะมีการขยายขนาดตัวใหญ่ขึ้นแล้วเรียกว่าเกิด hypertrophy นอกจากนั้นเนี่ยก็จะเริ่มมีเขาเรียกว่าเป็น matrix เริ่มเพิ่มเติมมาอยู่รอบๆ extracellular matrix เริ่ม initiate มากขึ้นในการที่จะมา deposit อยู่รอบๆกล้ามเนื้อเรียบของเรากระบวนการเหล่านี้ครับเริ่มตั้งแต่ hypertrophy จะเข้ามาสู่กระบวนการ compensate ก็คือ hypertrophy ที่มันเยอะขึ้นเรื่อยๆจนกระทั่งจุดใดจุดหนึ่งที่ร่างกายเราไม่ไหวแล้วเกิดการเสื่อมเกิด degeneration ของตัวกล้ามเนื้อเรียบหรือ endothelial cell urothelial cell พวกนี้จะนำมาสู่ภาวะ decompensate นั่นหมายถึงว่ากระเพาะปัสสาวะของเราจะไม่สามารถที่จะทำงานได้ดีอีกแล้วครับทั้งหมดทั้งมวลเป็นภาวะเป็นผลพลอยได้เป็นผลพลอยเสียที่ทำให้เกิดจาก Bladder Outlet Obstruction Bladder Outlet Obstruction ครับอาจารย์มันจะมีกระบวนการทางโมเลกุลหรือว่ากระบวนการที่เกี่ยวข้องกับการหลั่งไซโตไคน์หลายตัวด้วยกันที่มันเกี่ยวข้องนะครับตัวแรกเลยก็คือพวกเขาเรียกว่า transforming growth factor พวกนี้จะเป็นจุดเริ่มต้นที่ทำให้มีแคสเคดต่างๆตามมาอีกหลายชนิดนะครับมีโปรตีนที่เกี่ยวข้องไม่ว่าจะเป็น SMD type ต่างๆมีไซโตไคน์ที่เกี่ยวข้องconnective tissue factor พวกนี้ก็จะมากระตุ้นให้เนื้อเรียบเกิด proliferation เกิด hypertrophy แล้วเกิด deposition ของไอ้ตัวextracellular matrix รอบๆ smooth muscle cell เหมือนอย่างที่สรุปไว้ในท้ายสไลด์ครับกระบวนการ Bladder remodeling จะเกิดขึ้นด้วย3อย่างด้วยกันก็คือกล้ามเนื้อเรียบมี hypertrophy กล้ามเนื้อเรียบมี proliferation แล้วก็มี collagen มา deposition รอบๆกล้ามเนื้อเรียบในการรักษาต่อมลูกหมากโตครับยาที่เกี่ยวข้องจะมีด้วยกันอยู่2กลุ่มนะครับกลุ่มแรกก็คือกลุ่มที่เป็น alpha blocker ซึ่งจะดูแลผู้ป่วยพาร์ทไดนามิกทั้งหมดแต่ในพาร์ทสแตติกจะเป็น 5-alpha reductase inhibitor นะครับแล้วก็รวมถึงการผ่าตัด TURP หรือ POLIP แต่วันนี้เราจะมาโฟกัสในด้านของไดนามิกกันนะครับว่า alpha blocker มีโรอะไรยังไงซึ่งปัจจุบันนะครับ alpha 1 blocker ถือเป็นยา standard เป็น first line treatment ในการรักษา LUTS BPH ในผู้ป่วยที่มีภาวะต่อมลูกหมากโตจากที่กล่าวไปเบื้องต้นนะครับว่าสาเหตุของ tissue remodeling กับ Bladder Outlet Obstruction เกี่ยวข้องกับภาวะกระเพาะปัสสาวะขาดเลือดนะครับมีการทดลองที่ได้ตีพิมพ์ใน Journal Urology Professor ของญี่ปุ่นทำการทดลองโดยการใช้แคลมนะครับไปบีบตัว Bladder Artery แล้วก็ทดลองดูว่าหลังจากที่ให้ซิโอโดซินไปแล้วเนี่ยเลือดไปเลี้ยงตัวกระเพาะปัสสาวะแตกต่างกันหรือเปล่านะครับซึ่งหลังที่ให้ที่ซิโอโดซินแล้วเนี่ยเลือดไปเลี้ยงตัวกระเพาะปัสสาวะดีขึ้นประกอบกับมีการศึกษาหนึ่งนะครับเป็นการศึกษาถัดไปที่ ที่ได้ตีพิมพ์ทีมเดิมกับโปรเฟสเซอร์โกอีเนี่ยครับเขาได้ศึกษาโดยการใช้ตัวยูริธาของหนูใช้เชือกไปผูกแล้วก็ดูว่าให้ซิโรโดซินละเลือดไปเลี้ยงตัวกระเพาะปัสสาวะเป็นยังไงบ้างซึ่งผลปรากฏว่าหลังจากที่ผูกและให้ซิโรโดซินเนี่ยเลือดไปเลี้ยงตัวกระเพาะปัสสาวะเยอะขึ้นนะครับซึ่งเป็นสิ่งที่น่าแปลกใจแล้วก็ถือว่าเป็นประโยชน์ต่อผู้ป่วยนะครับว่าทำไมการให้ซิโรโดซินจะช่วยป้องกันภาวะที่ชูรีโมเดลลิ่งได้จากการทดลองในสัตว์เมื่อกี้นี้นะครับเราจะมาดูการทดลองในคนนะครับโปรเฟสเซอร์ฟัสโกนะครับได้ตีพิมพ์ในวารสาร European Urology ซึ่งถือว่าเป็นวารสารแรงค์ 1นะครับเป็นการทดลองดูว่า bladder outlet obstruction เนี่ยมันส่งผลกับคนยังไงและยาตัวไหนที่จะส่งผลต่อ bladder outlet obstruction นะครับโปรเฟสเซอร์ฟัสโกนะครับได้เก็บข้อมูลในหลายงานวิจัยและพบว่าซิโรซินเป็นยาที่ช่วยลด bladder outlet obstruction index ได้สูงที่สุดสูงกว่ายาอื่นๆค่อนข้างมากนะครับโดยที่ตัวซิโรซินเนี่ยลด index score ได้ถึง30แต้มในขณะเดียวกันเพื่อนๆนะครับไม่ว่าจะเป็นด็อกซาโซซินแนปโตพิดิลแทมซิโรซินอัลฟูโซซินหรือทราโซซินลดลงได้แต่ก็ยังสู้ซิโรโซซินไม่ได้ bladder outlet obstruction index นะครับมันจะเป็นหลายคอมโพเนนต์ปนกันที่ทำให้เกิดคำนวณออกมาเป็น bladder outlet obstruction index ประกอบไปด้วย PDET แล้วก็ QMAC สำหรับ PDET เนี่ยตัว alpha blocker ที่ทำหน้าที่ในการลดPDET ได้ดีที่สุดเนี่ยก็คือเป็นด็อกซาโซซินซิโรซินเป็นแรงค์2ยาอื่นๆออกมาเป็นแรงค์3 4แต่ซิโรซินก็ไม่ได้ต่างกับตัวแรงค์1ที่เป็นด็อกซาโซซินมากเท่าไหร่และสำหรับ QMAC นะครับตัว alpha blocker ตัวที่ทำหน้าที่ในการเพิ่ม QMAC ได้ดีที่สุดก็คือพวกที่เป็นนัปโตพิดิลซิโรซินออกมาเป็นแรงค์ที่2ซึ่งก็เหมือนกันครับพอมานั่งเขาคำนวณหาสกอร์แล้วเนี่ย bladder outlet obstruction index ลดลงได้สุดสำหรับซิโรซินโดยที่ประเด็นที่สำคัญหรือ key point นะครับก็เพราะว่าซิโรซินสามารถช่วยลด bladder outlet obstruction index ได้ดีกว่ายาอื่นๆในกลุ่มนะครับสาเหตุก็เป็นเพราะว่าเขาสามารถช่วยลด PDET ที่ QMAC ได้ดีมากเขาสามารถช่วยเพิ่ม QMAC ได้ดีเช่นเดียวกันนะครับโดยทำให้เนี่ย bladder outlet obstruction ลดลงมากกว่า30แต้มดังที่ดูไปในสไลด์ก่อนหน้านี้ครับสำหรับ key point หรือประเด็นที่สำคัญที่ทำให้ซิโรซินมีคุณสมบัติในการลด bladder outlet obstruction index ได้ดีที่สุดก็เพราะความที่มี affinity ต่อ alpha 1a ดีกว่า alpha 1b ถึง162เท่ามีที่ alpha AD ต่อ alpha 1D ได้สูงถึง55เท่าเลยทำให้ bladder outlet obstruction index ลดลงได้มากที่สุดเมื่อเทียบกับ alpha blocker ตัวอื่นๆสำหรับการศึกษาถัดไปของ Professor Fasco นะครับ Fasco ได้ศึกษาดู urodynamic กับ alpha blocker ยังศึกษาสำหรับการผ่าตัดร่วมด้วยซึ่งพบว่ายาซิโรซินมีประสิทธิภาพในการลด bladder outlet obstruction index ได้ดีที่สุดในกลุ่มของ alpha blocker แต่แน่นอนยังไม่สามารถที่จะสู้การผ่าตัดต่างๆได้ไม่ว่าจะเป็น TRP หรือ HOLEP สำหรับการเพิ่มขึ้นของ QMAC การผ่าตัดไม่ว่าจะเป็น HOLEP TVP TRP สามารถเพิ่ม QMAC ได้ดีมากเดียวกันยาซิโรซินก็สามารถช่วยเพิ่ม QMAC ได้ดีเช่นเดียวกันดีกว่า alpha 1 blocker ตัวอื่นๆด้วยซ้ำนอกจากนั้นสำหรับการลดลงของ PDET การผ่าตัดไม่ว่าจะเป็น TVP HOLEP TRP สามารถลด PDET ได้ดีซิโรซินก็ทำได้เช่นเดียวกันและเมื่อ subgrouping ยา alpha 1 blocker พบว่าซิโรซินมี affinity alpha 1a ต่อ alpha 1b ได้สูงที่สุดและมีการลดลง BOI ได้ดีที่สุดเมื่อเทียบกับ alpha 1 blocker ตัวอื่นๆกล่าวโดยสรุปครับจากข้อมูลทั้งการวิจัยและการศึกษาพบว่าซิโรซินมี selectivity profile ดีกว่า alpha 1 blocker ตัวอื่นๆจับ alpha 1a ได้ดีกว่า alpha 1b ถึง162เท่าจับ alpha 1a ได้ดีกว่า alpha 1d ถึง55เท่านอกจากนั้นเมื่อเรามาเปรียบเทียบ urodynamic efficacy พบว่าสามารถลดลง BOI index ได้ถึง30คะแนนและเมื่อเปรียบเทียบทาง clinical outcome กับ tamsulosin พบว่าสามารถช่วยลดอาการ emptying nocturia frequency ได้ดีกว่า tamsulosin อย่างมีนัยสำคัญสำหรับความทนต่อยาพบว่าการใช้ซิโรซินจะมีความทนต่อยาและความปลอดภัยสูงในผู้ป่วยที่สูงอายุกับผู้ป่วยที่มีโรคประจำตัวกล่าวโดยสรุปก็คือซิโรซินเป็น first line option ในการรักษาผู้ป่วยที่มีภาวะต่อมลูกหมากและ LUTS ดังนั้นซิโรซินจึงเป็น first line treatment ในการรักษาผู้ป่วย BPH และ LUTS ที่มีประสิทธิภาพดีที่สุดเมื่อวัดจาก Urodynamics
ครับก็น่าจะครบถ้วนสมบูรณ์นะครับเดี๋ยวก่อนที่เราจะจากกันมีเรื่องแจ้งอยู่ 2-3 เรื่องนะครับก็ ก่อนอื่นเลยต้องขอขอบคุณทางสปอนเซอร์ใจดีของเรานะครับที่สนับสนุนให้เกิดงานนี้ได้แล้วก็ช่วยซัพพอร์ตในทุกๆอย่างทั้งในเรื่องของการถ่ายทอดแล้วก็เรื่องของการจัดหาสถานที่ให้เรานะครับก็ประกอบด้วยทางบริษัทเอไซประเทศไทยจำกัดนะครับก็ผู้แทนจำหน่ายยายูริฟแล้วก็ยูริตอสนะครับที่2ก็คือบริษัท Boston Scientific ประเทศไทยจำกัดนะครับก็วันนี้ได้นำผลิตภัณฑ์ตัวใหม่ล่าสุดของบริษัทก็คือ Resume นะครับก็โชว์อยู่ทางด้านหน้านะครับก็บริษัทสุดท้ายก็คือบริษัท Olympus ประเทศไทยจำกัดนะครับวันนี้ก็มีของใหม่มาให้เราชมเหมือนกันก็คือตัว Sotif นะครับซึ่งเป็นทูเลียมไฟเบอร์เลเซอร์นะครับก็ท่านที่สนใจก็เดี๋ยวก่อนที่เราแยกย้ายกันก็สามารถที่จะแวะเวียนไปที่บูธนะครับไปดูหรือว่าขอรายละเอียดสอบถามเพิ่มเติมได้นะครับอาหารเย็นนะครับเดี๋ยวเรามีจัดนะครับเป็นบุฟเฟ่บาร์บีคิวนะครับก็ขอเรียนเชิญคุณหมอทุกท่านและก็ครอบครัวนะครับรับประทานอาหารเย็นร่วมกันนะครับเวลา 18 นาฬิกานะครับเดี๋ยวเราเจอกันที่ตรงริมทะเลนะครับก็คือเดินลงไปจนสุดเลยตรงริมชายหาดตรงนั้นเดี๋ยวเราจะจัดเป็นบุฟเฟ่บาร์บีคิวไว้ให้นะครับแล้วก็เดี๋ยวก่อนออกจากห้องนะครับเดี๋ยวผมรบกวนเดี๋ยวถ่ายรูปร่วมกันสักนิดหนึ่งตรงบริเวณแบ็กดรอปที่อยู่ด้านหน้าห้องประชุมนะครับก็สั้นๆแป๊บเดียวแล้วเดี๋ยวเราแยกย้ายไปพักผ่อนกันแล้วกลับมาเจอกันอีกครั้งหนึ่งตอน 18 นาฬิกาเพื่อที่จะรับประทานอาหารเย็นนะครับโอเคก็ขอบคุณทุกท่านนะครับก็ขอบคุณทีมทุกท่านมีพี่นาริสาด้วยที่มาร่วมแรงร่วมใจจัดงานนี้ขึ้นมาแล้วก็ต้องขอบคุณทางทีม Organizer ด้วยนะครับที่จัดงานนี้ได้อย่างสมูทที่สุดเลยนะครับขอบคุณครับแล้วเดี๋ยวเราเจอกันนะครับเดี๋ยวถ่ายรูปด้วยกันก่อนนะครับหน้างาน